day to you all. We are starting the program today. I am not saying good afternoon because we have got a global audience and it may be morning or evening wherever you may be. I am Suman Biswas. I am a consultant ophthalmologist here in the UK and an alumnus of JIPMER, the medical school in Pondicherry, India. The Alumni Association in this country, JAAUK, was very privileged and honored to have been officially recognized as a registered charity by the Charity Commission this year. And we are also an accredited CPD provider for medical and health education. When we were discussing about the theme for the CME this year, instead of focusing on a medical subject, we thought we will focus on the medics themselves, the international medic to be precise. We in JIPMER historically have had students from various parts of the world, and after graduation they have dispersed to all corners of the world. So for a long time we well understood the true meaning of the word international and the ultimate fact that the whole world is one big family. It is noteworthy that our Alumni Association is only the third in this country after the British International Doctors Association and the British Association of Physicians of Indian origin to take an active interest in IMG affairs, because IMGs in this country have been a part and parcel of the NHS for a long time. We plan to develop this in future and create a platform where we can not only interact with the various official bodies, but also serve as a resource for the IMGs themselves, so that they can look up for guidance and also their well-being. With that in mind, we have reached out to not just our own alumni, but to IMGs all across the world. And as we speak, we have got not just a sprinkling of IMGs here, but at least 49 registered attendees online and several hundred possibly who have not registered and watching us online. We hope that this meeting will be truly useful to them, because many of them will be looking to train and work in this country in the future, or already here looking for jobs. Without further ado, I would carry on with the CME. We have got eminent speakers and an excellent lineup of talks, and I'm sure you'll all enjoy it. Let's begin first with Nitya. She herself is an IMG, and kudos to her, she has found her first job in this country, so she has got her own unique set of experiences to narrate. Thank you.
Yeah, great. Thank you, Dr. Biswas, and thank you all for coming here today. So as Dr. Biswas mentioned, I'm Nitya, and I'm a fresh graduate. Not exactly fresh. I've been practicing medicine for about a year, and I've just come here and I've just got a job in Birmingham in Queen Elizabeth Hospital. And I'm here today because Dr. Prabha said I could come here and complain for about 10 to 15 minutes and everyone has to listen. I have a captive audience. But no, jokes aside, I'm just here to speak a little bit about the challenges that I have faced as an IMG coming into the UK. So I would say that there are two kinds of challenges that one faces as an IMG. We have your environmental challenges, which are physical challenges that moving from a warm climate to a colder climate, cultural differences, those kinds of challenges are there. And we also have more systemic challenges, which are difficulties that one might face while trying to break into a system like the NHS. So I'm just going to talk for about 10 to 15 minutes and just summarize all of that up for you. So, oh, I'm so sorry, I forgot I had some slides. Thank you so much. But I'll continue without them if that's okay. So the first challenge that I faced when I reached the UK in November of 2021 was the cold. So I had looked up, I had done some research, I looked on Google weather, what the temperature was going to be like, I packed warm clothes, but I landed in Manchester and I was still sort of not prepared for how biting the cold would be. And the other thing was that the gloomy weather in England was not just a phrase, it actually meant something. And I felt that it did have an impact on mood. It does affect IMGs when they come here. So sunny days, which are few and far between, are like quite precious to us. But again, that's something that you get used to over time. I'm sure that all of you all have been through the same thing. This is not a new story. Moving on, another challenge that I had faced was culture shock. So the most common challenge among those was the accents. So before I came to the UK, I was like, okay, I know that the accent is going to be a bit difficult to understand. I should practice, or I should like listen to something. So I spent a couple of months watching Downton Abbey. And when I landed in Manchester, I realized I should have been watching Coronation Street instead. So just a little anecdote for you. The first week that I had landed, after completing my quarantine, I went to Tesco to buy some food and just stock up on groceries. And I was initially stunned because I'd never seen so many different kinds of cheddar in one place. I was just staring at all this cheese. So then I pick something and I go to the checkout, and this really lovely lady in her lovely Mancusian accent said, "Cash your card, lovely." And I didn't understand what she was saying, and it just went back and forth like 3 or 4 times. And I finally understood, paid, and then I never went back to that Tesco again. So that was the little bit about accents. And another thing that I found really different, but I quite like about in the UK, is the endearments, just, a seasoning in the end of every sentence. I really like it, and I take it as like a daily dose of positivity. Coming from an Indian background where my mum is super, super sarcastic all the time, this was very different for me. And I said, okay, Ma, I'm coming here. I'm going to get adopted here. You don't need me anymore. People are nicer to me here. So that was another thing that I just liked here. And I was homesick quite a lot. And I'm sure that most people in this room have felt some form of homesickness once or twice in your life. And to that, I would say that what's really helped me was finding my tribe, finding a wonderful community of people that I can be a part of, meeting new people. So that was a challenge, but it could be overcome. Now, moving on to more serious issues, the actual meat of the topic was the dreaded job hunt. So the pathway that I took was the common pathway, which was the PLAB 1, PLAB 2, GMC registration, and then searching for a job here. And I just found that was very, very harrowing, because different people put different kinds of advice online, and everything is individual. I mean, it's based on their own experiences. So no one pathway actually suits everyone. And despite the fact that there was so much of information available online, I found it a bit difficult to navigate. For instance, some people were saying, you need to do a clinical attachment, otherwise there's no way you're going to get employed. But some people were saying that you don't have to do a clinical attachment, your CV is good enough. So there was a lot of difficulties that I had to navigate that way. And building my CV, which was something that I'd not really given much thought to earlier, I had to constantly be thinking about that now. The fact that I was working under a time constraint and financial constraints also was an issue. So basically, getting a job, your first job in the NHS, it's a balance of skill and luck, being at the right place at the right time, and also actually putting thought into your CV and trying to build that up, and networking. So all of that played a huge role. It was not easy, but I managed to get through it, and it's doable. So that was one of the larger challenges that I had. So basically, I'd made this very linear roadmap, and when I got here and saw the issues that I was actually facing, I felt that it looked more like an ECG. It was very bumpy. So moving on, another serious challenge that I felt that I faced was culinary challenges, because food is very important to me. It's one of my favorite things in the world. And having to actually cook for myself was difficult. And because I'm so used to my mom doing it or my grandma doing it. And honestly, food that is prepared by someone else always tastes better. So finding ingredients, roaming around, managing my own expenses, getting advice from friends, that was also something else that I had to deal with and overcome eventually. And to wrap all of that up, I would say that every cloud has a silver lining, even though the sky is like full of clouds over here. I felt that I'm quite happy with the path that I've chosen, despite the difficulties, because the benefits far outweigh it. I have met a wonderful group of mentors and friends here. I've built a community, and I feel that that's really helped me get to where I am today, and I feel like it's going to take me further. It's been a character building experience, I would say. It's made me more self-reliant, and I'm really excited to start my career here in the UK because I feel that I do have quite a large scope for career growth, lots of opportunities and options. And so I am planning to do my specialization here in the UK, and I would like to take an active role as you are today, like actually trying to make things a little easier for IMGs, a little clearer, provide some sort of standardized base where you can go to for advice and provide support, mentorship and guidance for future IMGs. So that is one thing that I'm quite interested in participating in the future. And just some sort of way to equalize these systemic differences. Coming in from India or another country into the UK, despite the levels that we'd reached at home, when we come here, quite often we have to start from scratch all over again. And I'm sure that there is some way to get over that, and maybe that's something that we can go over in the future. But that's all I have for you today. And without much ado, I'll just hand it back to Dr. Biswas.
Thank you, Nitya. That was a wonderful introduction filled with anecdotes, and we quite enjoyed your talk. I would next call upon Sri Buddhadev Pandya. Sri Pandya needs no introduction. He has been working with doctors, for a long, long time in this country, and he has got many, many successes to his credit. You can read the long biography that has already been published online for you. And Sri Pandya, over to you. Thank you.
Thank you very much for giving my background. First, I congratulate JIPMER Group to have been formally registered as a charity. All the voluntary organizations in UK of both alumni groups and the other groups, they play a huge role in order to support the BME doctors who come from abroad. They also play huge contribution in terms of now influencing the change in policies. This is where the whole concept of creating voluntary sector. So there is a role for voluntary sector in the healthcare system. I think if I would no, I'll just speak. Yeah, I think. Yeah. That is yours. That's yours. Yeah. Sorry. Let's come down. I think the British as a country has been dominating the world as we know it, from Indian subcontinent to others. So there is a different culture when we come round from countries like India or Pakistan. And the population itself has a English language and also has a Christianity culture behind it. And I think the lady found it very, very difficult, even initial conversation with the Tesco. And I think in my young days when I came from India, my lecturer says close the door, and I couldn't understand what he was saying. So obviously in the medical setup in hospitals, there are a lot of concerns about the people who come from abroad and can't speak the language. Although most of the Indian, Pakistani and Sri Lankan others who came here in UK had competency in English language, but in terms of understanding the pronunciations, and the special lingo, they were not there. But in time, it all captured very nicely. And I think one of the beauty of working in Britain is that over the period of last few, particularly since 50s, the culture has changed. It has adopted and try to what you call accept diversity within the efforts of promoting equality. Now I'll touch the equality issue in a few minutes. And I think the main reason for us, means BME communities, able to come here for specifically because there was a gap of skilled people with the knowledge about medicine, and country like India prepared the doctors through the education system, which was expensive here, but at India's cost they are prepared, and they come here and they work in this and in the NHS. So that was the first reason where the gap was filled by our people. Our means BME communities. The other was a desire from BME community, people of origin of a different country, to be able to go abroad and get more experience in terms of the quality of the education, experience in the hospital, which has got a much more better facility sometimes. Not nowadays. Nowadays you go to bigger cities in Delhi and Bombay and Bangalore. Those hospitals are really the A-class equipment and facilities. So those two and others came because they wanted to better their family's lifestyle and financial status. So I think with these aspirations, the community, the medical community came from abroad, and I think for many of them was a bit of a shock, because those who came from countries like India, they largely driven private sector, but also a public sector which was not that highly geared up, and there from them to coming to Britain, they came since 1950s onwards far more, and saw the National Health Service. And National Health Service was primarily publicly funded body, and that was also designed to provide a free healthcare service at a point of use without regard to their source of income. So for the newcomers, there was a huge culture shock, because the way you practice back home and the practice here it takes time to digest it, and it affects your conduct, it affects your thinking process. Now once you come to this country, you have 3 or 4 areas which you have to be careful. The first is you are employed by the NHS, unless you have a private company or you have some contract with the private sector big firms. So they are your employers. So you may have some contract, but they are regarded as employers under the new regulations if you are working as a consultant, but eventually you are part of the salaried staff. The other thing which you will come across, and which most of the people have to find, is the existence of the medical royal colleges, and they largely recognize professional bodies responsible for the development and training in the medical specialties. Then regulatory authorities, and this is the bodies such as GMC, General Medical Council. It is the most feared body in terms of medical professions, mostly doctors, consultants, surgeons, those who work in the field, because all my life, 25 years, I have worked in the healthcare system, and cases I have seen that every day most trained consultant will be going to the hospital and simply thinking, gosh, everything goes smooth today, because the moment something goes wrong, you fear that GMC will really rough you up. And once your problem is escalated to a disciplinary process, and if you're unfortunate, it goes to further GMC. It's a kind of, in English we call it dog's dinner. It becomes a dog's dinner, and legality is so complex, it ruins individual cases. And I think obviously there were a number of cases where people have committed suicide, and I think BME community has been more receiving blunt end of that. Now one of the area which now also is important for migrant doctors is a protection bodies. You got a BMA, which is a historically known registered charity type of body, which provides support as a trade union. and it's a trade union as well. So obviously there are other organizations which provide private sector indemnity, and like BIDA, British International Doctors Association, and BAPIO, and other organizations, and of course now you are a registered charity, you will also grow into that kind of field. So these are the voluntary sector who are specialized in supporting doctors when they are in difficulty. So newcomers have these 3-4 areas have to bear in mind. Most of you I can see here are fairly experienced, but the newcomers, as you found it, yes, of course, it's difficult, it's a daunting task. My take is this: after having spent so many years and helping doctors in difficulties, developing BAPIO-like organization from nothing to big, powerful group, and also medical defense shield where we protected people. One thing I have to say to people, that in order to survive in a highly fast-moving medical community in Britain, and NHS particularly, is to have a leadership attitude. Now, basic mantra is to survive, and progress is all about your own ability to acquire leadership quality. Now, leadership, we all talk about saying you run a big department, 400 people under you, 200 people. No, that is not leadership. A simple cleaner could be a good leader, because focus on the work, quality of the work, delivering target, that's called leadership quality, and coping with those things, prioritizing it. So those things are leadership. Without leadership quality, the chances are you will tumble up somewhere. The expectations from the NHS and the patients particularly, expect that you have a learning capacity to defining your milestones of clinical standards and administrative practices. We get so much worked up in the job that we miss those key, what you call the key pictures in front of you. So you need to focus, and you need to identify the milestone of a clinical standards. If you don't reach the clinical standards, you are in big trouble. Your administrative practices is another thing which has got many professionals in difficulties. How you keep notes, and how you keep advisory, how you liaise with other departments, how you manage your deal with your nurses, etc. These are the areas which, if you don't have the competency, you are in real trouble. The main areas of this, sorry, how much time have you got?
Sure.
The main area is the quality of outcome of our patients and meeting the fit for practice standards. If you haven't given thought to it, then you have to have a big picture of GMC in your bedroom to see when you leave home and when you come back. Keep an eye on, because that's where you tumble. That's where your whole ethics of leadership will come into play. And many of the migrant doctors who are junior trained to even experienced one, they don't take full advantage of training opportunities you get in the NHS and the surrounding areas. And their learning curve has to be developed with less of what you call a kind of arrogancy, and we know it better than somebody else. So unless you in leadership you develop the learning curve, you will find it very difficult to deal with some of the complex conflicts. The best practice is another one, which is a communication skills, and this is a masterpiece. If your communication skills lacking, please go and do the learning and develop those skills, because assertiveness is very important, and of course and seeking right kind of help. A lot of doctors get into difficulties, they do not go and seek help. So I think the another two aspects, one is the improving your behavior and conduct. Lot of efforts have to be made to ensure that you de-learn some of the ways your attitude goes in the workplace, because you need to be effectively communicating with your colleagues and your staff. You have to be familiar with zero tolerance issues on bullying, harassment, discrimination, women discrimination, all that. So your language, your loose talk when you are having a canteen cup of tea. I think One of the cases I dealt with in south of England, where senior consultants were talking in a swimming pool that we will teach these Asians some lessons, and it was picked up, and it was, they tried to hide it, but it got further, and then it was found out. And these kind of things, you lose talk somewhere. We do have people who are so hooked up on certain language, certain attitudes towards other communities, other religion. Please be careful, because a chief executive came and said, well, you have problem with the Indians and Pakistanis, haven't you? So this is where you have to be very, very open-minded and ask yourself, put a mirror to yourself, saying, you're looking for equality and justice. Is your own conduct is meeting those criteria? And the protocols must be learned about dealing with colleagues and patients. There is no escape from that, because nowadays you do a deal with a patient or a nurse, you are in trouble. Someday it's going to come back to bite you. The protecting your career. So obviously this is where your contract, employment contract, and your indemnity on personal liability, etc. You have to have a proper protection. So don't delay paying your subscription to BMA or any other organization, because the moment you go and you have a problem, they won't touch you unless you're paid members. And we have seen many cases in MDS where people have not paid their membership fee, and they say, oh, it's a little problem, please Mr. Pandya, can you help me? But you touch the file and it's this much high. It's going back 3-5 years back. So please ensure that your defense bodies, you have proper membership paid. I'm going to take a bit.
Yes, you have 5 minutes.
Yes, yeah, okay. Now, this will give you a solid platform, because young lady will learn within no time. By the time 5 years, her family will say, oh, you have come from England, now you become a British and you don't even understand Indian culture, because she said, this is very bad, we don't do that in England. So this language and cultural thing, my children grown up, they are all pharmacists, they are born in this country. Their approach to the medical health system is completely different. They are really in forefront, they are really looking for going up. They don't have problem with language, they don't have problem with the culture of the British culture or way of living. They are fighters. So that stage will go. What we will face, and we are facing, is what we call a racism, upfront racism, and many of our people who have been ignoring the fact that we are facing discrimination. And there's something called white pigs, and I think white pigs means on top, all white jobs are gone top level. But now I think with Sunak and Mrs. Patel and all that people, the white pig is melting a little bit, and a lot of our people are now into the medical, as a medical directors and so on. So they are going up places now. But racism, and when we dealt with racism, the teachers, the bus drivers, all they have stood up for their rights in Britain in 70s and 80s. The medical profession was attitude with, I am alright, Jack. I look after my senior and I'll be alright. It is until after late 90s when more ethnic minority doctors came from abroad and they realized the full blunt of the racial discrimination. And this is where we took up 2 cases. One was immigration, other was the disproportionate GMC exam results. So issue is about, don't wait until the hot oil comes under your chair or your seats. Wake up, be partners and participate in influencing change. So in your system, if there is the forum, if there are people who are negotiating, discussing, you have to participate. You have to see the system is improved and play a role into it. Don't expect somebody else to do it, like your organization or BAPI or BIDA or whatever. They shout in the paper and they compete, and then you say, they are politicians. But bit by bit, there is a change of attitude, and that's how the race relations law was introduced in 1995, which has made the difference today what we enjoy in this country because of that kind of political will to have a legal equality right. And if we don't recognize that, then we will be bigger loss. And over the period, I think institutions have realized that there is institutionalized racism and there are systematic failures by the managers not to tackle the issues before it hits the fan. So I think we need to be part of that rather than being a hero on a what you call whistleblower, because it's a very dodgy and a very difficult area to go into without knowing how political it will have ramifications. But by influencing change locally, improving things and playing a role with the entire system to make it important, significant change. We got 50,000 roughly. I will just conclude it. We are talking about a population of 1.5 million of Indian origin. We're talking about every 3 in 5 probably doctors who are from abroad playing a role. 60,000 Indian doctors work, that's approximate, in the institution. So we have enough support groups. Now every town has got temples and gurdwaras and little community centers, so you don't feel lonely about it. You won't miss now Indian food. You will find every town have a nice Indian restaurants, the best ones, yeah. So that is what I'm saying to you, that both the employment areas of your survival and your social life, if you don't tackle the social life with a balanced life, diet and exercise and mental health, I'm sure you will pay, your family will suffer. So I think mental health is the biggest issue coming up on board. So I'm saying a message to all generations who work in NHS, please focus on mental health as well. Make sure you don't isolate yourself in a stress situation, because ask for help. So I think that should be covered in my presentation, and I hope 2 things will happen. I have as a publisher, I do publish a journal, healthcare journal. It's a free of charge, and it's available on internet, and this is all research and innovation cover, so you are welcome to write anything here. We have 3 sections: cardiology, surgery and mental health. Other specialty are welcome, and there's a little form there, you can fill it up at the back and give it to me so I can put you on the list. But please do ask me questions when the slot comes in. Thank you very much.
Thank you, Mr. Pandya. That was a very illuminating talk, very insightful, and as you rightly said, leadership begins with our own selves. We have to be honest and moral in our own conduct, and then only we can expect the best from others. Thanks for all the good things that you said. I'm sure there would be questions as well, but we are running out of time, so we'll take the questions over tea time. We would now move on to the next talk. Dr. Chandra Sekaraya, Shashi for short, is a consultant in Preston, and he has been involved in training and mentoring IMGs for a number of years, and we would value his inputs and his experiences as well.
Thank you. Thanks very much for the organizers for asking me to speak today. I think before I start, it's a great privilege when you see one of your mentors and your teacher coming to listen to you. And in the audience I have Dr. George, was my consultant and my mentor in 2005, my first anesthetic job in the UK. So thank you very much, Dr. George. So when I thought, how shall I focus my talk, or how do I go about my talk, and I looked at the audience, I think the range is from somebody who's in India looking to move to UK or thinking about moving to UK, to the other extent of people who've been in the system for years, contributing in different roles in the NHS. And so I thought, if I reflect on my own journey, how I started from the time I decided to move to UK, and over the years, based on my experience, what I learned and what I've done over the years, along with people like me or like-minded people, how we all thought, how can we make system easier for people like us who come to the NHS or join UK. So I thought, as a journey, what were the jams I had, multiple potholes I had to navigate, plenty of tolls, obviously, as you all know, and finally the safe roads. I mean, that is what we're getting to. How can we make this journey on a safe road? Some of my things I do at the minute, so just in the interest of time, keep moving. So the first thing I want to focus on is, when you start with an IMG, as most of you, as either as a mentor or educational supervisor, says I want to move to UK, the first question, either as an IMG or you as a mentor, need to ask is why? Why you want to go on this journey? What are your family circumstances? The cost, do you know how much it will cost? Are you able to meet that cost? Skills and competencies, do you know you have the required skills or the experience of the jobs which are available? And then obviously have a plan B. So if I look at all these, I didn't think about any of these when I first came in 2003. The reason being, I finished in 2002, I didn't do any post-graduation in India. I came straight through. The only thing is I didn't have any sort of an option because I was the only doctor, the first doctor in my whole family. And my dad had died the previous year. The expectation was the doctor is going to come and solve all our problems. And I was expected to earn from day one. So I went to the IMA library in Bangalore, if any of you have been there. It's like basically there are people sitting in the same seat year after year preparing for PG. And I was thinking, I don't think I have this option of sitting here for years while the debt is mounting. So what is the option, other options? And somebody said, oh, PLAB, it's an investment. But at the same time, my dad had died in an RTC with a splenic rupture, and suddenly you think somebody shouldn't be dying of this. So that's where my interest in intensive care came. So how can I develop intensive care? Yes, that is a dream, that is your career option, but at the same time you have your family to feed. So what are your options? So I didn't have to go through much, I didn't have much options. And that time, Citibank, if somebody at that time remember, Citibank was a big thing in India, was trying to launch. So if you give your medical certificate of your MBBS, they used to give a lakh loan. So that was my first investment into PLAB, and that's how I came here. So things not to do. So if you're thinking about now, what are your options? Where are your options? Look, what are the various things in terms of your journey, your family, how it's going to fit with the rest of the things. So the traffic jams, as I talked about, first thing to look at is current job opportunities and competition. So looking back into the numbers, in 2004, there were around 10,000 people who sat PLAB, 6,500 people had passed PLAB, of which only 3,500 landed in the jobs. So no surprise when I landed in 2003, July, it was February 2004 when I got my first job. So your homework becomes very, very important. How do you click on the link? How do I click on the link? So, second. Don't have a mouse. I just need to click on that. Yeah, so first thing to look at is the competition ratios and what's happening. This is what is currently happening. So in 2004-05, we had the highest number, then came the MMC, which suddenly said if you're an overseas doctor, you can't apply for a training post. So suddenly a lot of our dreams were shattered. I couldn't get into a registrar number, though I had the SHO number, so I had to wait till 2010 when the whole court order was reversed. By then, a lot of IMGs lost hope in NHS and left. So since then, went down the IMG numbers. If you look at here, that stayed for quite a long time. Even in early 2012, 2013, there were hardly any IMGs coming to UK. But what's happened now? In 2020, we overtook the local graduates. The number of IMGs registered with the GMC was more than the UK graduates. So obviously, there is a supply and demand at the minute. So people are getting jobs, but this is not going to sustain for long. And if you also look at the numbers, still PLAB seems to be the most favorite in terms of people coming through UK, but our gaps are all at a registrar level. So if people are coming with PLAB with no postgraduate experience, they are likely to struggle far more compared to somebody who's got the experience. So I think you need to look at what are your options in terms of moving forward. So as an IMG to work in the UK, you need to have demonstrated knowledge of English. That's your IELTS or the OET. GMC registration. In the next slide, I'll show you what are the ways of getting GMC registration. Then you have the qualification relative to the job offer, and the visa. Things are slightly changed compared to what we were. So initially, once you pass your PLAB, and you need a job offer for you to get the GMC registration, whereas now, as soon as you pass PLAB, you get GMC registration. So what are the other routes of getting your GMC registration? So PLAB is the most common. The other thing we call the medical training initiative or the sponsorship program. So if you are done a post-graduation training up to 3 years in your specialty, you can come to this MTI program or the sponsorship programs. For some of you might have known by the ODTS, which was previously the same thing. If you have completed any of the UK membership exams, like the MRCP, I think it's more of the anesthetics ones are related, but any of the membership exams, if you're done in the UK, you get the GMC registration as well. Again, some of the postgraduate qualifications, some countries are recognized, and obviously that's the PLAB. So you need to be aware what is the best route. So if you're a postgraduate practicing for 10 years, there's no point for you to sit PLAB at that stage in your career. You can look at the sponsorship program. So you need to be aware of how can I move into the UK. So, and the next thing comes, okay, you know what sort of route you want to come, what are the requirements, but you need to understand how the system works and how your specialty works. So some understanding of your specialty as well as the NHS makes a huge difference for your decision when to move. Even it may be the pay scale. So there are a lot of doctors who come to the UK thinking that, oh, I'm coming into a training post, I'll be a consultant. So if you think about it, 95% of the jobs, if, for example, of those 11,000 people who registered with the GMC, there's only a handful of doctors who might have ended up in a training post or a consultant straight away. Most of them end up in what's called a locally employed doctors, which are most of them not recognized for training or you to become a consultant. It's more of a service provision jobs. Yes, there will be opportunity to learn, but you need to be aware that you need to put a lot more effort once you're in the country to get into this training program or to become a consultant through the CSER program. So just understanding your specialty as well as the NHS is more important. This is some of the work we did with our own specialty with anesthetics and ICU. So the King's Fund is a very good area where you can get an understanding of the NHS. There's a nice sort of video, 5-minute takes you through the whole sort of the organizational structure of the NHS. This is what we did with the Faculty of Intensive Care. What we've got is an IMG section on the end where we've clearly listed what are the opportunities, how does the training in ICM work in the UK, and all the stuff. So for somebody who decides or wants to come to UK for ICM training, they can go through. So I think it's very important that people understand how your particular specialty works so that they could, before they make that big move. Family. So how does it fit in with the rest of my family? If your family is a non-medical person, so how does his or her job fit in once I move to the UK? I mean, currently at any point of time, I employ around 19 to 20 IMGs in my ICU, and it's number of times where the family members are either like an architect or an engineer, somebody who's come and sat home for 2 or 3 years doing nothing. It becomes really difficult from the family side of things. One of the things we've done in Preston is started something called an apprenticeship for some of the family members. Then we can see if they can fit in into any of the jobs available in our own trust. But not all trusts will have that option. So you need to think about how will my family fit into this. So that's sort of my initial sort of a traffic jam sort of a thing. So negotiate, sort of know where what are your opportunities, how to negotiate. Potholes, plenty. GMC registration and visa, the first thing. As we said, now it's far more easier with the GMC registration, but be aware again with the whole GMC registration process. Simple example, the GMC says once, even if you've got GMC registration, when you apply for it either through PLAB or the MTI program, you need to be in a continuous employment in the last 12 months. I had a couple of my IMGs who were doing an attachment. The attachment means different thing in India and different thing in the UK. So attachment for some of the IMGs in India means you're working under somebody. Whereas attachment in UK, that you're not hands-on. So they were refused GMC registration because they felt they are not in continuous practice in those 12 months. So be aware of what the requirements are. Again, visa. Your visa is specific for the particular trust. you're working. So you can't work in anywhere else. So if you're looking for some multiple training opportunities which are in multiple hospitals, then you need to think about moving jobs every 6 months or 12 months. Along with that comes with the visa cost. It's one of the more expensive ones in terms of the cost of the visas. I mean, we calculated on me, my wife is a neonatologist, when we calculated when we became the citizens, we had spent around £22,000 in our stay till from the time we came to the time we became British citizens. So there's a huge visa cost as well, along with a lot of other costs. NHS is different. I think we've already touched upon. I'm not going to touch much about it. Same thing with the new culture in society. So how do you adapt? Again, there's various things you can do to help it. I think I'll focus more on that. And the other thing you always find is you have to prove the system time and again, more so than anybody else. There's always things when you come first that people think you. So most of us are the way we are all apologetic, very trying to please somebody, and we downplay our skills. That sort of a lack of confidence sometimes is almost thought as incompetence. So how do you make people train in such a way that yes, you need to demonstrate your skills, but at the same time be confident, at the same time knowing where your limitations are. As I said, non-training posts, we already touched about racial differential attainment is a big thing at the minute. So what is differential attainment? So either because of your race or your gender, you have less chance of being successful in a particular job or a role. We've looked into in the faculty ST3 appointments, it's a big thing. So you're almost 50% chance of passing through the interview compared to a UK graduate who's around 95%. It's not just racism for that. We know there are a lot of other factors. That is what we are working on. Again, I think the GMC is big into it, and every college and every faculty now we need to report in terms of what are the measures we are taking to address these sort of issues. Career progression, as I said to you before, yes, you might end up with a job within the first 6 to 12 months, but how are you going to progress in your career? Are you going to get into a training post in a specialty which you wanted? Are you going to become a consultant at the end? If you think about most of the jobs in the UK, the training numbers are not going to increase much anytime soon. What the system requires is the service jobs. How are you happy doing those roles? That's what you need to think about. Tolls, as I said, plenty, GMC registration, GMC visa fees. You don't, again, at least it's a month, 4 to 6 weeks from the time to arrive in the UK to get your paperwork sorted, so you need to fund yourself. Then comes with all the living costs, especially if you've got a family and kids, then what about your schooling? If you think about private schools, then that's another 10, 15 grand for each of them. Exam and courses, none of them are cheaper. Most of us ended up, I think again, same thing we touched earlier about the passing rates in the exams. So one of the common things I find with my IMGs is they've never failed an exam in their life and they fail at ALS. So these courses, there's multiple costs involved. And then obviously you need to visit your family back every time. If you've got a family of 4, imagine the cost every year. And one of the things, the feedback I get from some of the IMGs or even my whole cohort of friends who have not visited their families for a few years is the cost. Suddenly, if you look, every India visit costs you 4-5 grand every year. So can you meet that? So you need to think about how the rest of the stuff is going to fit in. So what I want to focus in the next few minutes is about how can we make this journey safer? What we've done with a lot of like-minded people, along with working with all the organizations, and what have we done so far. The good thing is the system will benefit a lot from an IMG. I'm sure most of you have worked with the IMG doctors in your specialities. The system recognizes these are a bunch of hardworking, highly motivated doctors, and they have been regarded very highly in the system. And also, the system has quite a bit of, in terms of the capacity to train, both in terms of skills as well as leadership and education. So the system also has the capacity to train. What else do the IMGs offer? Currently, increased sustainable workforce, decreasing local spend. And again, it also helps to develop close working relations with societies around the world. Again, supporting education. I think some of the things we've been doing is, Irene, one of my RMTI, is setting up the simulation course in Nigeria. We are supporting. So it also helps pays back to the countries where they come from as well. So IMG support. These are some of the stuff which we have done over the years. I think it's now recognized nationally as well. There's an IMG enhanced induction, I think, going to talk about, but I'll briefly touch on it. And these are the things you can do to make their life easier. First of all, what have we done? most of us understand that before they come to the UK, they need to have some understanding of your system, some understanding of your hospital, have a brief idea about the things they need. So this is what we've done in Preston, is as soon as anybody gets employed while they're in their home country, we send this document. So this might be your costs. This is a checklist of things you need to do. This is the nearest airport. This is where your accommodation is. And these are the various local, okay, don't bother about carrying tons of your masalas or anything. We've got everything. The local shops are here, the temples are here. So they get a sort of a free information as soon as they get employed while they're in their home country. Other resources. This is the enhanced induction I talked about. I think they'll touch on it briefly later. What are the different, there's all like an e-learning material, how to work, introduction to working in NHS, social hospital, various topics related. GMC runs a welcome to UK practice as soon as they come. It's a half-a-day course, it's online at the minute, but I'm sure hopefully it will get in person soon. It talks about all these topics. So there are already resources available, so you don't need to invent anything new. Does it work? It's not working for the link, sorry. Buddy and peer support. This is something, it's not very. This is one thing which we've developed in the last few years. Some of my colleagues in Manchester do it. What we do here is allocate a buddy. So if I'm employed by Preston, on the day of my appointment, what I get allocated is an IMG who's been in the system for more than 12 months. This person becomes the point of contact for this IMG while they're in their home country for everything in terms of the support. They don't replace your educational supervisors or your clinical supervisor. These guys are for the pastoral support, how to find the accommodation, how to find a school. Okay, if I come to Manchester, how can I come from Manchester to Preston? So this has been well received, and the guys who had those mentors are now becoming mentors themselves or the peer buddies themselves. And a lot of places which are doing this one have had a very good feedback, and the enhanced induction, which is GMC and all the organizations have endorsed, talk highly of this having a peer buddy system. Relocation allowances. Not all trusts have it. So this is where you guys as leadership roles, when we are in leadership roles, how can we push for these changes? So all my IMG, when they first get employed, get £4,000 as a relocation allowance in the first salary. Because this is to cover for the cost of the travel, the first month where they're not being paid. So this covers. So when you're doing a business case of putting new posts in, this is something you need to think about and impress on the managers that the need of this sort of relocation allowances. Enhanced induction and supernumerary period. The supernumerary period is one thing I think it's very difficult to convince your managers. So basically you're going to pay somebody for a period of time without them contributing to your on calls or to your rota. It becomes very difficult to prove, but over a period of time you need to convince the long-term benefits of doing that is far more, both in terms of the financial as well as the patient safety. And one of the things I always talk about is patient safety. I think once you start on that angle, I think there's very little your managers can go back. So enhanced induction and supernumerary period. So this is the document I've been talking about. I think that the next speaker is going to briefly talk about it as well. So this is, we've been doing it or pushing for last many years, but finally all the organizations mentioned now have bought into it, and this is like a national program now led by Professor Mala Rao, and a lot of contributions from people around the country saying that we need to make sure they need to have enhanced induction, which will involve supernumerary period, peer buddy, and all the things it's coming as part of this document. The next thing is about educational supervision. Gone are the days saying that, I think before they always used to this thing that, oh, why does an IMG or a non-training doctor require educational supervision? They were working in isolation on their own with not much of support. Even now, I think there are lots of trusts where they don't have no support in terms of educational supervision. And one of the things we've been pushing, again, the enhanced induction document talks about, is every doctor working in the NHS should have a nominated educational supervisor, to both in terms of support, both for clinical as well as the non-clinical stuff that I'd like. So this is a brief from that particular document which says when you're having an initial education supervisor meeting, there's a checklist about what are the things you should be talking, what are the things you should be supported with. So make sure either if you're an IMG working, make sure you have access to this document, and also if you're an educational supervisor, take it with your departments to say, why are we not meeting these? Extra support, exams, again, this is one of the things you learn over the years is it's not what you want the IMG to do. You need to sit with them and find out what is their career intention, what they want to get out of the job, or what they want to do while they're in the UK. So, what are the various reasons people come to the UK? One, they come as an MTI program, 2 years or 3 years, depending on the specialty, then they have to go back. So your role as education supervisor or mentor is, in these 2 or 3 years, what this person want to gain. There may be a particular skill they want to gain in those 2 or 3 years, or they want just the experience. You need to make sure that you have a system in your own organization to facilitate that. There's no point pushing that person to say you do exam because you think exams are good. Yes, you can suggest it, but we can just facilitate what they want. Training post, yes, that person might be interested in a training program. Then you make sure that you signpost to people who might help them build their CVs to get into a training program. And some of them have got few doctors who come and say, I just want a work-life balance. I don't want any exams. I don't want to get into training posts. I just want to work 40 or 48 hours a week and just want a nice work-life balance. Okay, fine. You just facilitate that. Okay, you gain this. It may be in that. If you have a special area of interest, we will develop, we'll support with that. There's few of my doctors have decided we've just facilitated that way. Then LED doctors, the locally employed doctors, again, these are for short period. They want, again, similar like a SAS, who want for a longer period. These for shorter period, they want to work for 2 or 3 years and just go back. Yeah, we'll facilitate that. Caesar is a big thing now. Again, I don't think that itself is a talk by itself. Basically, Caesar is an alternative pathway to get into specialist registration because of the training numbers not increasing, and with the experience of the OCs or the IMGs, there are a lot more pressure, a lot more emphasis currently on Caesar. I said both I'm a Caesar assessor for both anesthesia as well as ICU. We've seen a big rise in applications. So if you're an IMG who's got 10, 15 or 8, 10 years of experience in a particular specialty, look into how do I meet the Caesar criteria rather than working in a non-training post for years. How can I get in on the specialist register using Caesar? Every specialty has got some specialty specific guidance, SSG, on the GMC website, which clearly gives what are the requirements to meet the Caesar criteria for that particular specialty. So look into that. Exams, some of them comes, I just want to finish an FRC and go back, and we've done that. So especially some of them work in the corporate sector, they say once they do the exams, it increases their both professional career progression as well as pay. So they've just done the exams and gone back. And then subspecialty exams, experience. So some of them come for cardiac, peds, or whatever subspecialty experience they want, we try to facilitate. And again, going back to when you're thinking about the jobs, you need to understand how the UK works. So for example, if you want a cardiac anesthetic experience, you know now with the UK is more of a spoke and hub model. There are only few centers who do cardiac. So if you're taking a job in some remote place, there's no way you're going to get any cardiac experience. So you just need to, that's where understanding the system becomes important. Okay, so I'm going to end by saying the last slide about the things we have. Next one. That's fine. So one of the things we've done is, I think there's a brief talk about communication. What we did initially was I've employed in the last 6 years as a consultant around 100 IMGs into my ICU. And what we noticed was they were all skills was absolutely fine. It was the communication and the human factors. And what we did was we did some initial simulation work with my own IMGs. And after a period of time, we took it to the Royal College. And what we now run is a simulation course for all IMGs in the UK who come to anesthetics and ICU on human factors and communication skills. We're looking into now to develop it across all other specialties to just make it as a generic IMG, human factors and communication skills. I think that's one thing which people find it very difficult in the initial period, and that's some of the things we need to focus on. Okay, so I think the take-home is just, I think IMGs are a valuable member of the NHS. We make more than 1/3 of the NHS workforce at the minute. Enhanced support is the key. As I said to you before, I think that initial period, hand-holding period is the key for them to get used to the system so that their confidence doesn't go, any incident in those periods, I think the confidence goes down very rapidly. So we need to make sure they're well supported. Peer support I talked about, whether in terms of buddy support or as your education supervisors. Education and training in new areas of practice and communication skills. Again, there is enough opportunity for career progression, learning, and work-life balance. I think it's people like us now at a different stage in the career where we can take leadership roles. We need to challenge the system to make sure the right support and the opportunities are provided by the system. There is still a bit of a lottery happening where it's not uniform across the UK. There are places which have very good support system established. At the same time, there are still places where they end up with being on call in the first or second day. We need to work to make sure this sort of practice doesn't happen. And it's already alluded upon. Local and national leadership roles are key. You need to be in these roles to make this change. We can't just sit outside and keep complaining. We need to be inside the system to bring about these changes, and whatever things I've influenced has been in the last 3-4 years since I've got the national roles and the trust leadership roles. I think we need to work on these to see how can we make a change. Thanks very much. Sorry if I over.
Thank you, Shashi. That was a very informative talk. And you've given us a lot of pearls, not just for the IMGs, but also for those who are mentors and educators and appraisers and senior people. And I think it will be very, very useful to act upon all your suggestions. We definitely want to get rid of potholes and have smooth motorways. So can I request you to come and sit on the panel, because what we'll do is we have another speech, another talk, and then we'll take questions. I would like to invite Mrs. Janet Gray next. She trained as a nurse, but she works with the GMC. So we will get an insider's view from the GMC about what IMGs are about and how we can help them. So we look forward to your speech.
Thank you very much. Thank you, Dr. Biswas. How long do you want me to speak for? 10 minutes?
15-20 minutes.
Oh, right, okay. Thank you, Dr. Biswas. And I would say good afternoon, good morning, because I'm really glad that we've got such a wide audience from all over the place. So welcome, everybody, and thank you for inviting me. I was really privileged to be asked to speak today, and I think the theme of the day really chimes with the GMC's message at the moment. It's a focus on the workforce and members, not they're the most important thing. So that was really heartening. Just a bit of a background about me. Dr. Biswas, thank you for your introduction. I was a nurse. I'm now working at the GMC. So at the moment, the team I lead are outreach advisors. We go out to speak to cohorts of doctors, really engaging with the front line to talk about the GMC. I've heard Dr. Pandya, I know what you said. We are the most feared organisation, and I think my team and the GMC, we want to try and get that message out that we are much more than the big bad wolf that is fitness to practice. There's a lot of things we're doing to support doctors in the workforce, particularly international medical graduates. So it's great that we've got this opportunity to have a talk about that today. So just on the theme of today, I'm conscious that a couple of things I was going to talk about have already been covered, and in the interest of time I probably will skip through some of these quite quickly, but you've got all the links and the information on the slides anyway. But I'm going to talk a bit about the PLAB test. I know it's been mentioned before. There's a video. I'm going to suggest that, especially if you've got people in the audience dialing in from overseas, if you've got colleagues, friends, family, yourselves who are interested in coming over, there's some really helpful information there that I would advocate looking at. Routes to registration has been covered. I'm going to skip through those quite quickly. Talking about the Welcome to UK Practice workshop that we run. The NHSE standardised induction, which is a fantastic and really important innovation. And finally, I want to talk about our equality, diversity and inclusion targets. We know from our research that doctors from BME communities are more likely to be referred to the GMC by their employers, and we're doing a lot to tackle that and to really work on that discrimination. So I'll talk a little bit about that later. So just moving on, again, talking what Dr. Shashi said about the licensed medical workforce. We are really, really grateful for IMGs coming over. They are the backbone of the NHS, and you'll see the figures on the slide there. This is from our latest State of Medical Education and Practice Report 2021, and there's an increase of 6% increase of international medical graduates coming over this year, and 17% of IMGs made up the trainees in the UK last year. So really important that we welcome everybody, and more importantly we support doctors coming over from overseas so that they really are able to thrive in the UK. I'm not going to labour too much on this slide about the types of registration. People ask me what route should I go, what registration should I have. It depends on what you're qualified in, where you got your PMQ, what experience you've got. Speaking to people who've contacted me and my team, colleagues in the contact centre at the GMC and also in registrations. If you go onto the website and you're following the form, it's quite an interactive tool to find out what was best for you. But if in doubt, please don't hesitate to phone up colleagues at the contact centre. I don't know whether, Nithya, you've had any experience, but they are really helpful to try and navigate through, because it just depends. Everybody's case is so different. There's some nuances. People have got different experience. So the message there is please don't hesitate to contact the GMC and have a look at that. Shashi's also mentioned the sponsorship route, and again, it's for a talk for 10-15 minutes, it's not enough time to go through this. I just wanted to highlight it as you have. Each sponsor's got their own scheme. These are all approved by the GMC, and again, I've put the link on the slides which I know are going to be shared with everybody. So there's information there to have a look at, and if you have got a lot of postgraduate experience, as we've said earlier, it's no point doing the PLAB, that is for more junior doctors, but having a look at the sponsorship schemes. And just to send the message out, we are absolutely looking into that and exploring that at the moment. How can we make this more streamlined? How can we help doctors who want to come and practice here, make it easier for them to get all the information? So that's a work initiative that I'm involved in at the moment, trying to streamline. Do we need 900, whatever it was, pieces of information? So watch this space. There will be information coming out. We've done a few surveys on sponsorship and people who are offering fellowships to see how is it working on the shop floor. And that's another great thing about the outreach team I work with. We are not just going out talking to doctors, but we're bringing that intelligence back as well. What is working, what isn't working? How can we help the GMC do our job better? So there's an awful lot of work going on behind the scenes on that, so watch this space. But as I say, there's a lot of information on the sponsorship route on the website, so have a look at that if that's something you're interested in. Talking about PLAB again, and that is where most junior doctors come over to us. So we've got the PLAB test, and it's important that there's English language as well. We know that communication, I live in Liverpool and people say I talk very quickly, so I'm trying to moderate today. I won't use any Scouse slang, but it is really difficult. When I worked in Wiston and the Royal Liverpool and doctors coming over, it took a long time for them to get to know what we were saying, and you call everyone love, okay love, and these endearments that Nithya was talking about, and it is difficult and quite a challenge to get used to colloquialisms and what does that mean, and it is interesting. But the English, obviously, for obvious reasons, you know, we do have this criteria that English language is important. So the pre-requirements for a PLAB, and probably these few slides are more interesting for perhaps members of the audience here in person, if you've got young people or colleagues or friends, family want to come over, but also for colleagues who are joining us online who are perhaps thinking about coming over to the UK. So again, we've talked about the necessary English, and any doctor that contacts us, they'll get a GMC online number. This is your 7-digit unique reference number. As soon as you get that, it doesn't mean you're registered, unfortunately. That's just your number, so that if you do contact us. But it's really important if you're wanting to book a PLAB place and pay for the place and organise if you need to change dates or whatever. And anything that you need to do or any contact with us, we've got a record so we can keep up to date. What did you ask us last time? What did we going to say that we were going to help you with? So really important to get your GMC online account. So this is the slide I was talking about. For those of you who may not be as familiar with PLAB, it's in 2 parts. So part 1 is the multiple choice questions, and you hear different anecdotes about these. There's 180 questions that you need to do in 3 hours. It's quite tricky, and it's not about remembering stuff, it's how your clinical experience can be put to good use to care for that patient, that scenario. So it is quite onerous in some ways, but you know, it's important that coming over to pass this PLAB test, you know that you've got the experience you need. And it's designed to assess, we were talking about if you've got lots of postgraduate experience, this isn't the route for you. It's for the junior doctors who will be on a foundation year 2 level doctor in the UK. And you need to pass both parts. So the PLAB 2 is the practical thing that we've set up in Manchester. And just to give you a few figures, so, I need my glasses. We've had an absolutely exponential rise in the demand for PLAB places. So I was interested in your figures about how they've gone up. So between 2012 and 2016, average was between 2,500 to 3,000 requests for a place a year. This year we've offered 15,000 places, which just chimes with what you said, how many IMG doctors are coming over. And of course we've had to accommodate that, and what we don't want to do is put people off coming over. So we've increased the number of days in our PLAB 1, doing that in the four parts of the UK as well as overseas. And we've also increased PLAB 2. So for the PLAB 2 now at the assessment centre in Manchester, we've now got 3 circuits for OSCEs, so we're really trying to meet the demand of IMG doctors coming over. But the thing I would say, if especially for the audience overseas, have a look at that YouTube video, and it's what I wish I'd knew before I did PLAB, or everything I need to do about PLAB. So really useful resource there to have a look at. We've also mentioned the standardised induction. This is absolutely brilliant initiative. Marla Rao, I don't know whether anyone in the room knows Professor Rao. She's fantastic. Really does get things done, really pushes things. So since 2019, we've been working with MRES and NHS England and BMA, Health Education England, because we recognised, and I'll talk a little bit about some of the research we did in 2018, but doctors not having a proper induction, especially doctors from overseas, that is a real gap and a big pothole, I would say. And this is why our data shows that on the Fair to Refer report, which I'll mention in a few minutes, doctors from overseas are more likely to get referred to the GMC. And part of the problem, when you unpick that, okay, a doctor might have got into difficulties, but let's see, how did they get there? Did they have induction? Have they had peer support? Have they had a buddy? You know, has anybody given them some timely feedback to say, oh, maybe not do it that way? So it's really important. And we're not talking about your induction where you do your manual handling and you know where the fire escape is. It's a proper ongoing. It's not, you know, a 2-day thing to tick box. It's a really important fundamental induction, and having all of these skills and this peer support as well as educational support. We've gone through the evaluation of a few pilot sites, and the evaluation report is going to be finalised in the autumn, and we're hoping it's going to be published in BMJ Open. But the take-up and the appetite for this is absolutely phenomenal, which is great to hear. So it was launched on the 27th of June, and our Welcome to UK practice workshop, we always wanted to be able to say that should be mandatory. As a regulator, we can't say that. As an employer, the NHS England teams can, and because it's part of this standardised induction now, that's a real breakthrough, I think, that everybody on this induction programme has our half-day workshop for Welcome to UK practice as part of it. There's also a link here. I'm great with the links because I'm conscious of time. There's stuff that you can take away and have a look when you've got more time at your leisure. So there's a link on there about a bit more about this induction package. And as I've said, Welcome to UK practice is part of that. We are now doing these back face-to-face. So just to give you some figures there on the slides, in 2020, 3,760 IMGs attended one of our Welcome to UK practice inductions. 96% of those doctors said that they would change their practice as a result. They found them really useful, and they would improve their knowledge, not just of the GMC and our role, because I think some people, some doctors, if you're not as familiar, and it is scary, your regulator is scary. I know as a lawyer, and when I was a nurse, if the NMC or Senior Solicitors Regulation Authority letter plopped on my mat, I would be very nervous. It is scary, but we need to get that message out about what our role is. It's not just about taking doctors to task if they get into difficulties, it's all of the other stuff we do as well. We had the University of Newcastle independently evaluate our Welcome to UK practice programme And again, that was really positive. 2/3 said they'd made changes to the practice and they would really recommend it to colleagues. One of the things that's come out of the induction pilot is the same. And it's interesting, the induction pilot was talking about all the things we knew and chimed with what was said in Newcastle. It was really interesting about just how to be in the UK, what the NHS looks like. And there's a few recommendations come out of that, a few more tweaks of things we can do. We're always on about learning and getting this feedback, so again, we're looking to improve that. And just to say, the trusts that have got the induction programme, we're doing this regionally sometimes, so we've got local trusts. If there's a few IMGs in the trust or in the region, we'll go and do a local face-to-face workshop. We still run virtual workshops online, which I have to say, if I was coming over to the UK, I'd want to be in a room with other people who are in the same sort of position. I think the peer support and having that networking, you know, where did you go to Tesco's? Where do you get your groceries? How do you send your children to school? All of that sort of peer support is, and pastoral support is as important as what happens in the hospitals. We've still got the ones running Manchester and the London office. But again, if we know there's a demand, and this is one of the things my team does, if we know there's a demand, we will go out and deliver this. So if you know anyone who's in the UK and has been over the last 12 months or so and hasn't been on one of these workshops, please do get in touch, or get in touch through your regional liaison advisor to see if we can get them. We've now got a dashboard so we can see where people are and we can say, do you want to come to this? It's really, really useful. I'm just going to talk a little bit about supporting the profession under pressure and the work we're doing on equality, diversity and inclusion. I think it really chimes with the agenda today and some of the things we've heard about. So back in 2019, on the back of the case involving Dr. Hadisa Bawagaba, which I'm sure you're all familiar with, we commissioned these 3 reports. We wanted to look at how can we support doctors. We knew that the environments that doctors are working in will have an impact on how they practice and on patients' care, and we commissioned these 3 reports to see how can we improve that. What were the issues? You know, we heard all the issues, we heard all the feedback, and quite rightly it was important that we took the ball by the horns. Let's look at this. How has this doctor got into this position? Is there anything we can do as a regulator to help with this? So we've commissioned these 3 reports. So I think the independent review of gross negligence, manslaughter and culpable homicide, there were a lot of recommendations to come out of that, not all for the GMC. And in fact, these 3 reports, there was a whole host of recommendations. As a regulator, there's stuff that we can do, there's other stuff that we need to work with stakeholders and our system partners to do. But the fair to refer I mentioned before, one of the things that came out was induction is really important, and there's a real change, and that recommendation has been acted on. Fair to refer, we know that from the research that doctors from a BME community are more likely to be referred by employers. So another thing that my team do is talking to responsible officers to see whether that referral is fair, and I'll come into that a little bit later on. And then the other report, caring for doctors, caring for patients. If doctors are looked after and supported and have somewhere to go and have a coffee break and go and have a sleep if it's quiet, if you're allowed to, you know, somewhere to just sit down. I read something in a Sunday newspaper, which I won't name, I don't always read it, but it was talking about a junior doctor. There wasn't even a chair, they're sitting on the clinical waste bin. It's just ridiculous, isn't it? You know, if you haven't got that environment and safe and inclusive and well-supported environment, then how are you going to provide better care? So better cared and supported doctors will provide better patient care, which is what we're all about. So the 3 main themes that came out of these reports that we're really tackling and working on at the moment is equality, diversity and inclusion, well-being and support for doctors, and compassionate leadership. We've talked about leadership today, and Dr. Pandya and other speakers have said it can be anybody. It's not just the leaders that you see as the CEOs, it's anybody, you know, junior doctors coming in. If you see behaviour that's inappropriate or could be racist or bullying, call it out. You know, we're all leaders and we can all do our part for that. So that was 2019, all of those reports were published, and we had this fantastic programme of work we were going to come out, we were going to do all sorts with. We had roundtable meetings with NHS England and other regulators, and how are we going to really get to grips with this? And then COVID hit us, so all our lovely plans were a bit scuppered. What we didn't want to do This work was about supporting the profession under pressure. They were never under more pressure than in 2020. Even now, we're still not out of the woods by any stretch. So we didn't want to get in the way, so there was a lot of stuff that we were able to do behind the scenes that didn't need to impact on doctors, not getting in the way of doctors providing care on the front line. But I really like this quote from Charlie. You know, there's no shortage of warm words when it comes to tackling inequality and unfairness in medicine. But it's time now to really tackle this. No time for words. We've got to get our sleeves rolled up and put this into action. And we need to come together. And I think the pandemic as well, there's a lot of good stuff that come out of the pandemic in terms of team working, more cohesive, more supportive. And we just need to harness that and make sure none of that is lost as we go forward. So what we've done particularly on this, in May last year, we published our equality, diversity and inclusion targets. And they're set out on the slide there. We want to eliminate disproportionate complaints about ethnic minority doctors by 2026. Disadvantage and discrimination in medical education and training by 2031. And this all relates to differential attainment as well. Why are people not doing as well? Is there any ED&I issue there? And also increasing our own diversity. We've got to walk the walk. You know, I've been at the GMC since 2003 and we have got a more diverse workforce, but we're still on a journey. We need to get people to come and work for us. The registrant body that we regulate are so diverse. We need to have employees and people talking to them that are, you know, as diverse. People come to work at the GMC, they'll look at who here looks like me. Why are these all white people? So we are doing a lot of work with targets when we're doing recruitment to make sure that we have got a more diverse workforce that will have different perspectives. So it's stuff that we're doing internally as well. I think they're quite ambitious targets and quite rightly ambitious, and it's really important that we hold ourselves to account. And part of holding ourselves to account was these regular reports. So we looked at this in March and did a report on our targets as a bit of an update. And again, I've put the report link on the bottom there if anybody's interested in reading this. But it's really to keep that momentum going. Right, we've done this. What else can we do? What's working? What isn't working? We're doing a lot of work with responsible officers. If they have a doctor who's in difficulty, part of my team, the employer liaison advisors, will speak to them. How do you know this? How can you assure us that this referral is fair? Has this doctor had an induction? Have they had support? Who's made this decision? You know, we've talked about a trust in the north who've got a group of doctors now. It's not just the responsible officer. They've got a decision body of 3 independent people to have a look. Is this fair? Is this a referral? Which is fantastic. And that's the sort of best practice we can share to try and get those initiatives working across the board. We're running a lot of ED&I workshops. This is where regional liaison advisors will go out to groups of doctors talking about well-being, professional behaviour, talking about leadership and management as well. And looking at human factors guidance for investigators. You know, nobody goes out to do something deliberately wrong or get into difficulty. And we've got to take into account human factors. And this is one of the things that came out of the research after Dr. Bauer-Garber. What was going on? What was the environment? What else do we need to take into account? And I think the other thing just to focus on is the continued audit of our fitness to practice as well. How are we doing that? Are we being fair? Is this referral fair? So there's an awful lot of work going on. So on the March report, which was our first annual update, Charlie, again, the early indications are good. There's some good stuff going on, but we can't be complacent. And I think that is the message that comes right down from the top. We're on a journey. We can't lose this momentum. It's so important. The issues are long-standing. You know, we've talked about this for a very long time. We need to make time to work through this. So the headlines from the report in March: the gap between employer referral rates for ethnic minority doctors and IMGs compared to white doctors is now reducing slightly, which is great news, and there's a lot of work we still need to do with that. Fairness measures for medical education and training are similar levels, and one of the things we're doing, because we work with the education providers across the UK, we're working with them to look at their ED&I action plans to make sure they're as good as they can be and as robust as they can be, looking at differential attainment. And as an employer, we've improved our ethnic minority workforce representation at all levels. So that's really good news as well. We're looking at this internally. that was all I wanted to say. I know that was a bit of a whistle-stop tour. I'm happy to take questions on the panel, or is that... All right, so, okay. So thank you very much for your attention. I hope the information was useful. Thank you. Thank you.
Thank you, Janet. I'm Manu Matthew, consultant ophthalmologist, and it's been a real pleasure to have such a variety and diverse set of speakers who've covered a large number of topics in such a short time for all of us. And it really makes us think about how we can, as now sitting from the point of view of a consultant, and how we could have changed the progression of a doctor when they come to UK, and how they can go from becoming another doctor in the system to becoming a leader in the system. And that's what we want our doctors to do, is to achieve the maximum. And we now have Professor Dua, who would be giving us the talk on leadership, on how international medical graduates can progress in that direction. So I think this topic is something which is very dear to us, international medical graduates. And from that perspective, the first thing I'd like to say is that this memorial lecture is about Professor Matthew Krishnan, who started a career in India as an international medical graduate. And she never came to the UK, but she had the opportunity to train in India, to develop her training, and worked around India. So he will be speaking on this memorial lecture itself. And she actually worked in JIPMER for almost 5 years. And during this period, she had made some immense changes in the way practice changed, in the way JIPMER eye department worked. So we decided to do a memorial lecture in her memory. And so this gives us an opportunity to have a succession of meetings with memorial lectures where we could have speakers speaking on this topic. And Professor Dua has kindly agreed to be the speaker this year. Professor Dua needs no introduction. He has been a leader in ophthalmology for many years, and he has led the department of ophthalmology in Nottingham since the 90s. Before that, he trained in India, trained in Nagpur, and subsequently came to the UK, and he decided to do his fellowship in the US, and then came back. So I think he will be talking a lot about his progression, and I don't think he needs any introduction to many of the ophthalmologists here. But to just cover a few things, he has been the president of the European Society of Cornea, the Oxford Ophthalmology Congress. He has numerous publications, over 200 publications in ophthalmology, and has been the editor of the British Journal of Ophthalmology, and has been the past president of the Royal College of Ophthalmologists, apart from being the commander of the Order of the British Empire as well. So with those few words, I would like to request Professor Dua to enlighten us on how to achieve leadership in your specialty.
We weren't going to have a panel discussion before.
No, I think I'll just add the point here that the panel discussion can wait till we finish Professor Dua's lecture and see how we move ahead with that as far as time is concerned. I'm sure there will be plenty of time at the end to take questions on all the topics, and then we can have any questions beyond that. We can take it over a cup of tea or coffee.
Well, thank you very much for that invitation and the introduction. It is customary at the start of any eponymous or named lecture to say a few words about the person after whom it was named, but I only found out that it is named after Professor Miriam today morning, or when I came here. but Manu has done a good job in introducing the lady who did so much for JIPMER ophthalmology and Indian ophthalmology. So what I'm going to take you through is my journey from studentship to leadership, starting in India, like for most of us in this room, and then working my way through the system, through all those hurdles Sashi has mentioned, through all the compliance and regulatory affairs that Janet has mentioned, and sharing experiences that the other two speakers have mentioned. Reflecting on that journey, I at some point came up with these lines, that life is a summation of the opportunities that present and the choices one makes when those opportunities present. My first opportunity was in school, and I say that was my first encounter with destiny. There are 2 points in my career where made me firmly believe that there is a destiny. It's written. One of them is this. My dad was an Air Force officer, and I wanted to be like him in the Air Force, wearing a uniform, etc. My mom's dad was a doctor, and she wished me to be a doctor, but she never pushed that, and she was quite happy for me to join the Air Force. But my dad said, no, you have to go to university and get a university degree, and decided I would become an aeronautical engineer. In fact, at that time, the word aeronautical was not in my vocabulary. It was an aeroplane engineer. My mom never said no to all of that. But you may have heard of this story where a little school boy was asked to write a little paragraph on my ambition in life. And he came and showed that to his dad and said, look, this is my writing. My teacher asked me to do this, and I got good marks. And the father read that, and the end of it was written, and therefore when I grow up, I want to be an actor. And the dad said, well done, but the correct spelling is D-O-C-T-O-R. That wasn't what my mum did for me. So I went to school, and if you remember, some of you may, that at the age of 14, we have to decide to take physics, chemistry and mathematics to become an engineer in class 9, or take physics, chemistry and biology to become a doctor. And at that age, for some reasons unknown to me, I was in Gwalior, they did not take boys in the girls' high school after class 8. So I had to leave Gwalior and go to Delhi in the Air Force Central School, where I joined a boarding class, and we had to arrive 2 weeks before school started. There I made friends with a boy called Kanwaljit Singh Sarai, but I was all destined to become an aeronautical engineer, physics, chemistry, mathematics. 2 weeks, Kanwaljit and I, very good friends, a lot of time together. Then what happened, first day in school, I went to my class and he wasn't there. I said, what's happened to him? Why hasn't he turned up? So first class, second class, after 3 periods we had the small break, and I went to the field outside the play field, and there he was. I said, where have you been? He said, where have you been? I said, I was in class. He said, no, you were not. And I said, well, turns out I was in 9A, physics, chemistry, mathematics, and he was in 9B, physics, chemistry, biology. So he said, what are you doing there? Come to B. So I picked up my bag, went and sat, physics, chemistry, biology, and I became a doctor. That was my first encounter with destiny. So whatever you do, do it well. You can succeed in anything you take, even if it is not your first choice. I joined Government Medical College and Hospital, Nagpur, India. And there, after my graduation as a doctor, Professor Ishwar Chandra, the professor of ophthalmology, encouraged me during my undergraduate days to take on ophthalmology, and I took on ophthalmology as my subspecialty interest. Reminds me of Henry Adams' quotation, a teacher affects eternity, he can never tell where his influence stops. So find inspiration and be inspired. That was my message to everyone: look for somebody, someone, something, a role model, and that will be a great support through your career. So I did all the usual things, and I progressed to the post of reader in ophthalmology in Nagpur, and I did a few qualifications along the way. But that was not enough, because you hear about all these wonderful things that happen in countries like the UK and the USA and how progressed they are, and you want to go out and see some of these. So having learnt the first lesson, do the basics right, I learned that get an inquisitive mind, start asking the questions. And we call it broadly research, but it's not research as you and I thinking, breaking test tubes in a laboratory. Just start asking the questions, and at least give it a try and see where it takes you. I wrote this editorial in a Brazilian journal, and the link is there, it's free to download. As a medical student in Boyd's textbook of pathology, this was the first time I encountered that sentence: the eye cannot see what the mind doesn't know. And D.H. Lawrence expanded that by saying, what the eye doesn't see and the mind doesn't know doesn't exist as far as you are concerned. And I went on to modify it even further, saying there's a difference between seeing and looking. Only when you can look at something and see beyond what your mind knows can new discoveries be made. And that is how Newton discovered gravity, Archimedes discovered the principle of flotation, and Alexander Fleming discovered penicillin. All were little accidents in nature, in laboratory. They stopped to ask the question, and they came up with things that changed the world. So taking a moment to pause and think of what we see is all that is needed to allow the eye to see what the mind doesn't know. Seek opportunity if it takes time to present. So, like I said, I wanted to go out and learn more about the subject, and if there was no opportunity coming my way in India, I said, let me go out and seek it. And that's where I started playing the snakes and ladder game with my career. I was a reader, ready to become a professor, when this snake got me, and I came to Huddersfield in 1983 December, cold winter night, as an SHO in ophthalmology. Everybody said, get into a teaching hospital. At that time, there weren't rotations. You were either in a district general hospital or a teaching hospital where you progressed. So I applied for an SHO job in Nottingham in 1984. I was not shortlisted. And I carried on in Huddersfield, and I get a job as a locum registrar in Aberdeen, where I came under the wing of Professor John Forrester. And when I speak to people who know him and ophthalmologists, I say the rest is history. But he was a very good mentor. And the message there is, find a mentor, like I said, a role model, befriend him or her, and make it a lasting relationship. 40 years later, in this country, he and I still communicate, not just on ophthalmology, on other matters as well. And I have 3 such mentors who have made this long-standing relationship with. Working under John Forrester, now a little bit of science, I'm going to tell you, very simple to understand. We see these eyes with a large abrasion, which is stained with fluorescein, and everybody is trained to measure the long and the short length of that, the 2 longest lengths of that, and record that in the notes. I was intrigued not by the large abrasion, not by the empty part of the cup, but the full part. Why did this epithelium survive when all of that had gone? And that led to a series of research findings, which we concluded actually the first a set of established rules of corneal epithelial wound healing, which is a circular abrasion does not heal by forming circles of reducing diameter. Instead, from the remaining surviving epithelium, you get these convex sheets. They meet each other, they undergo contact inhibition, they form geometric shapes, which then heal by forming Y-shaped contact lines. And this became the standard. It was there in front of everybody's eyes for years and years, but putting them together in this story, purely clinical observation, no fancy high-tech research, but it changed the way we think about corneal abrasions even to this day. And here are some examples. You can see this becomes a quadrilateral and that Y-shaped contact line. Here's a beautiful pentagon that ends up with that Y-shaped contact as a quadrilateral, and here again you see that Y-shaped contact line. And these cells around it, much like iron filings around a magnet, you see those lines in these are, which are now clearly established patterns of corneal epithelial wound healing. But when looking at those patients, we came across some other patients where actually that part had also been affected, the limbus, where the white of the eye joins the black of the eye is called the limbus, and that's where the stem cells live that replenish the surface. And we looked at those, when we looked at those eyes and we started looking how they healed, this was hitherto never described that from the remaining intact epithelium, these little tongue-shaped projections form which migrate circumferentially till they meet, and then it becomes like an abrasion with an intact limbus, and it follows the first set of rules. And this became well established as a consistent pattern, and today it really guides our treatments of this condition and stem cell deficiency. And here's some examples. You can see a large, all that is green is where the epithelium is lost, which is blue is where the epithelium is on. So you can see it's migrating circumferentially, they're tending to meet along, and while that is healing, the conjunctiva is also migrating centripetally, coming here to meet, and they eventually meet. And when they meet, the cornea gets covered with corneal epithelium, the conjunctiva with conjunctival epithelium, and normality is restored. And that became the second set of rules of corneal epithelial wound healing. And you can see over here, clearly illustrated, when the limbus heals, you can see that there's a line of fluorescein staining because that's where these two sheets have met, and there's a triangle. And if that sheet moves in, you will get this Y-shaped contact line, which is exactly what you see over here when that heals. So very, very consistent pattern of healing. Looking at these further, and this is where disease came into the picture and how we can treat it, is sometimes the conjunctiva actually reaches the limbus and crosses before these two can meet. And then you get an area of what we call conjunctivalization of the cornea, which is literally the clear hallmark of limbal stem cell deficiency. And these eyes are prone to erosions, they're prone to vascularization, poor vision quality if the visual axis is involved, and lots of other issues, scarring, etc. And here you can see is an example of that. Cut a long story short, but you can see that bit of surviving conjunctiva is moving in while the circumferential tongues of epithelium are doing what we said in rule 2. And here they've actually crossed, and when they cross, you get an admixture of two different phenotypes of epithelium, and that part becomes very thin, irregular, attracts blood vessels, and when it gets into the visual axis, vision is compromised. So that is how, from a simple observation, my research journey started in Aberdeen under the guidance of Professor Forrester. And I mention this because this was my experience. Your teachers and trainers will always stand by you. Cherish this relationship. Become a doctor before you become a subspecialist. Learn to walk before you want to run, and that is a well-known adage. Now, having worked in Aberdeen for 7 years and learned a lot of things in the UK, there was still more to be learned, and I was seeking opportunity. And I was already a senior registrar. You know, in those days we had SHO, registrar, senior registrar, consultant. That was the career progression. I'd done my senior registrar training. I was in there, ready to be a consultant. Then I said, this snake got me, and I came down, not that far, but there to become a fellow in cornea specialization in the Wills Eye Hospital in Philadelphia. At that time, when I was going to Philadelphia, my mother said, don't you want to settle in life? You keep moving from one place to another. And I remember telling her, Mom, there's a difference between stagnation and settlement. I don't want to stagnate. I want to settle when I've achieved what I want to achieve. And that's when I decided, no matter what, and I was going there at a cost to myself. We all mentioned about cost, traveling from one nation to other, going through all their licensing exams, resettlement, no relocation expenses. it was a price, but education and training are priceless investments with lifelong dividends. Avail as many opportunities as you can get to learn. I don't know who said this, but it's profound. A doctor is a student all his or her life. In other words, when he or she ceases to be a student, he dies. And that's what you will notice. 90%, and I say this, 90% of what I do today is not what I learned as a trainee all those years ago. Everything has changed so fast. And the pace of change is so rapid that in the youngsters' lifetimes, things will come, they will be practiced and rendered obsolete not once but several times. Medicines will come, procedures will come, techniques will come and go. That is the pace of change, and we have to keep on top of that. Therefore, we remain forever a student. In America, I met these two individuals, Larry Donoso, Peter Leibson. These were my mentors, and like I said, these are the two other people who I still remain in contact with. Peter has got Alzheimer's now, Larry, so he doesn't correspond that much. But Peter, every 6 months, 3 months, calls me, speaks to my wife Rita, speaks to me just to see how we're doing, and I reciprocate. At that time, working under Peter, coming back to this corneal wound healing pattern, there were cases where these whirl patterns were appearing on there, just like a whirl pattern on the eye, and this was described as hurricane keratitis, which is because it resembles the symbol of a hurricane on a weather map. And these were described in the literature, and they were described as seen only in patients who have had cornea transplants, and that this pattern is because the way the cells migrate, determined by the sutures that have been placed to hold the graft in place. And that was well established, well accepted explanation for this condition. Until I saw this patient who has a beautiful hurricane but no stitches, no graft. So there's something else going on. So like I said, little things come before your mind. They are simple clinical observations, not high-tech data obtained from machinery, etc., but simple questions. So why is this so? Why? Therefore, they are wrong. It can't be only sutures. And we took this further on, and to cut a long story short, we were able to show that this represents the normal pattern of corneal epithelial cell migration in a whirl pattern, be it illustrated by the rapid migration and turnover of cells or by the deposition of pigment, and that whirl pattern is always there. And then we, with the help of a professor of engineering in Canada, came up with this hypothesis that the cells are responding to the electromagnetic fields of the eye, and they will always work in a clockwise direction because the current from the eye goes from the front to the back. Therefore, according to the right hand rule, the fields will be clockwise, and that's why you can see radially migrating cells will be twirled round in a clockwise direction. And we took this further by actually doing experiments, growing cells, and you could show that when cells are grown on magnets, this whirl starts to form, and then they become these beautiful whirl-like patterns, and you leave it for a while, and it unfurls and then disappears into the periphery. And here again you can see beautiful examples of this whirl pattern in cultured epithelial cells. Now this looks like the Whirlpool galaxy, but it's not the Whirlpool galaxy in outer space, because this is the Whirlpool galaxy in outer space. Again, all related to electromagnetic fields of planetary bodies and how they revolve around the sun. My next opportunity, and I told you 2 bits of destiny for me. Here I was in Philadelphia, settled over there, ready to become an associate professor. In fact, I already had the title of associate professor, having lunch in the basement of this building. Now they moved to this one. And I got a phone call from a member of the Senate of the University of Nottingham, followed by a phone call from the dean saying, "We have the chair of ophthalmology in Nottingham. Are you interested? Will you come back?" The same place where I was not shortlisted for an SHO's job. And of course, at that point, I realized the more snakes you encounter, the greater are your odds of finding the ladder where sky is the limit. Of course, my wife also had to come along, as you said, your family. So we took family along, made sure she got a job before I took on the place, and we both came to Nottingham together. The next thing is, when you've achieved that place, it's not the end. You don't put up your feet and rest on your laurels. Carve yourself a niche. Project yourself at meetings and conferences. You have to sell yourself. If you rest on your laurels or put your feet up, you will stagnate. Do something which nobody else does in that area, or very few do. So you become recognized, you become the world's expert in that area. And that's what I did with the stem cell research. I just started that theory, which is one trail of my research. We found patients coming to us where that conjunctiva had already grown on the cornea, and you can see that part of the cornea is conjunctivalized. This is the normal healthy part, and the vision is very poor. And what we found is, just by scraping that epithelium, that wrong epithelium away, creating an abrasion, letting it heal from here. So if this wants to grow in, you keep scraping it away. And I used to call it scraping until you get the visual axis covered by the healthy end. Within 7 days, the vision improves quite dramatically. And then somebody said, no, we can't call this procedure scraping. It's very important. We'll call it sequential sector conjunctival epitheliectomy. And that's a standard surgical technique now. All the textbooks for treating this kind of stem cell deficiency, very early stage of stem cell deficiency. So the scraping word, even the patients didn't like. I'm going to scrape your cornea. They say, no. So what you say, I'm going to brush the cells away. And they let you do exactly the same thing with a sharp knife, if you use the right term. And then we started doing stem cell transplants, and you can see eyes which were as bad as this and this. We converted to eyes like that with doing the stem cell, all because we understood more and more about this limbal stem cell deficiency, the limbus where the stem cells live, and how we can use the surviving ones to repopulate or transplant from a living relative or from a cadaver. And here are some other examples of this limbal stem cell surgery, which we pioneered in the UK from Nottingham, and we're still one of the world's leading centers for that. We also did many other things, and here's one new classification of chemical burns, which is now known as the Dewar's classification of chemical burns, and is the most popular accepted classification, prognostic classification of chemical burns. Corneal vascularization is an enigma. We don't know how it occurs, why it occurs, how to treat it, and forced by an intraoperative situation where there's a lot of bleeding from one of these blood vessels in the cornea. Normally the cornea is avascular, and that's where you can see this thick fibrovascular front. If you do a cornea graft, you cut it, it bleeds like crazy. So we came up with a technique. Here you can see how to stop them. So we take a fine corneal needle and touch it with a monofilament cautery, and it cauterizes that blood vessels along the length. It's called fine needle diathermy occlusion of corneal vessels. And again, it is now one of the standard techniques for treating corneal vessels, even though we now have anti-VEGFs and we inject antivascular endothelial growth factor alongside it, but the established vessels do not respond to that chemical treatment. They need this type of cauterization. So all these became entrenched in our armamentarium of techniques to treat corneal diseases. And here's another example. You can see this is the patient before, this is the patient after the treatment, some intracorneal hemorrhage, and when it settles, this is how the patient looks. All the vessels have gone, and now if you do a cornea transplant, the risk of rejection goes down because the vessels have been treated. We discovered some other techniques. I'll just go, this is a technique for treating recurrent corneal erosion syndrome, a very, very painful technique, and Manu was involved in this work as well. So ask these questions all the time. And I came across this quotation again, my favorite quotation in my professional life. To ask a question is the beginning of learning. And we asked many questions, as you see. To answer the question is a test of knowledge. And we tested knowledge and we created new knowledge in the process. But to question the answer is the start of wisdom. So you have to question even the answers that you have provided. Find the answers and question them. And this is exactly what we did here. All my first half of my life telling how important the limbus is. Until these patients came along where the limbus is completely destroyed, but the central epithelium is surviving. Then how can that survive if there are no stem cells? And we were able to study this, and we were able to postulate that the limbus has minimal role in physiological turnover of the epithelium, the epithelium can turn over itself from the basal cells, which are transient amplifying cells, and that if there's injury, then you need an intact limbus to regenerate, as I showed you in the earlier slides. For example, if there was an injury to this eye and all the epithelium is lost, it would not regenerate because there is no limbus. Then all this I did and much more is not by myself. It's all part of a team, and your team are right from nurses, from the cleaners who come and do your office up every day and sort your papers, your secretaries, your doctors, your juniors, and so on. I've got an anecdote over here. I was in the clinic one day and my normal nurse didn't come. My normal nurse used to come 11 o'clock every day, make me a cup of tea, prof, okay, close the door. And some other nurse had come because she wasn't there. And she was a senior nurse in a dark blue uniform, standing like that. First patient, second patient, 1.5 hours went by. 10:30 she said, seeing that there's nothing here for me to do, can I go? And I said, well, seeing that there's nothing for you to do, you can make me a cup of tea. And she said, what, me in this blue uniform? What do you expect? I said, sorry. I asked, Katie makes me tea every day. That's why I asked you. I make a cup of tea for my wife every day in the evening. I don't mind. And it's all about team play. If you were busy, I'm gladly make you a cup of tea like I do for my wife every day. And then in a flash, it occurred to me, by the way, I said, do you know that 3/4 of team is tea? Look at that. And she looked at me like that and said, for that, I will make you a cup of tea. And ever since then, whenever she came to my clinic, she made me a cup of tea. So respect your colleagues. Peer recognition is the highest form of recognition. Your seniors will appreciate you. They've taught you. You are like a child for them. Your juniors will always appreciate you. They will look at you. But your peers are your strongest critics because they are your rivals. And when you get peer recognition, you have arrived. And lots of this happened. All the papers I told you, these are just a snapshot of the papers. They have been confirmed by others. They have been reproduced by others. They have even been enhanced by others saying, yep, that works. Yes, that works. We've tried it. Randomized controlled trials showing that is the best method, and so on. And just, I don't want to read this to tell you, but the point these make is that. Finish off with the last bit. The last part, or rather a second part of the research is this cornea transplantation. This is how they used to do it in the early days, and I've seen these patients with square grafts walking in Philadelphia. And I used to tell my son, when he saw this picture, this is what happens if you see too much television. We used to, for more than 100 years, do cornea transplant, cut the whole circle of the diseased part out and put a new one in. The epithelium, the stroma, and the endothelium, the whole lot. But the endothelium is the one that rejects the most, and then the graft rejects. And the commonest solid tissue transplantation done in the world is cornea transplantation. The rejection rates are higher than for kidney transplantation. So we lose a lot of grafts because of that. And people have tried every which way to reduce rejection. All the biological methods did not help as much until surgery came to the rescue. And in that surgery, the answer was that if the endothelium is not involved, like in these patients where the stroma is involved, save the endothelium, replace the rest. Then you don't get endothelial rejection, but you get all the suture-related problems and the little scarring and the astigmatism and the warpage. But if the endothelium is involved, just strip the endothelium off the patient and put a new one in. Don't do the whole thickness, then you don't have any of the suture problem. Within 3 weeks, your vision improves, because if you've taken stitches, it can take up to 1 year until you adjust them to get the focus right. So we do endothelial keratoplasty. And while doing this first operation, to separate the endothelium with this technique called the big bubble technique, we inject air in the cornea, we blow the endothelium away from the rest, we take off the top, we cut what's left at the bottom to take out the entire stroma along the circumference, leaving the patient's endothelium behind, and then put a new cornea from which we've taken the endothelium. So it's like almost full thickness, 95% of full thickness cornea with the stitches, but no donor endothelium. So rejection is eliminated. This was the technique which was called the big bubble technique, where we are bearing the Descemet's membrane. While doing this technique, we came across something which nobody else had observed or had not stopped to think about, and we were able to show that when you get this big bubble, and this is in a human eye bank eye, you can create that bubble with air, but you can take away the entire Descemet's membrane, which is the one we're trying to separate, but that bubble doesn't burst because underneath there is another layer. And this layer is now the Dua's layer or the pre-Descemet's layer, which has completely changed our thinking about corneal surgery and corneal anatomy and corneal pathology. And there's a lot more about it, which I'm not going to tell you other than one or two things here. Anecdotically, so it was defined, it was published at this paper, Human Corneal Anatomy Redefined, and we had lots and lots and lots of positive, there were only 3 negative papers in the beginning, but whenever anything new is discovered, people come away, you get 4 kinds of comments. One is, it can't be true. The other is, it has been described before. The third is, I've described it before. And the fourth is, let's check it out and see if it's really true. And the fourth is fortunately the most common, and it has been corroborated, and this was 2013, so much water has flown under the bridge. And we got, for the first time, the University of Nottingham, the Times Higher Education Research Project of the Year Award. These are 2 other members of my team for this work in 2014. So that was a big achievement for the university and for me personally and for my team as a whole. And this is us proudly smiling in front of every entrance to every gate of the university had that for 2 years. The other people then made models of it. They borrowed material from me. They presented this work, and this was in Paraguay group. This lady got the first project in the national competition, first prize, and then she went on to publish it, present it in the South American Continental meeting and got the first prize there as well, and so on. Now it has been demonstrated in the living eyes by in vivo high frequency optical coherence tomography, and you can see that layer is over there between the Descemet's membrane and the last row of keratocytes. This is what it has done. It has improved our understanding of corneal surgery. It has made corneal surgery safer. It has led to innovation of 3 new surgical procedures. It has provided explanations for some of the findings seen in many corneal diseases. There are more than 600 citations, and many have corroborated and added to our findings. And its role in glaucoma is being studied, because the glaucoma is one of second most common blinding condition in the world, and that's the impact. So a little observation has gone such a long way. And just to illustrate this bit, in the early days when I presented this in a meeting in the Middle East, at the end of the talk, when I presented the first evidence about this layer, one doctor came to me and said, and I took this as a very, as in fact one of the best compliments, that I'm not surprised that you discovered this layer. I'm surprised that I did not, because I see it under my own eyes every time I do this operation, and I never stop to think about it. So that is simple observation. None of my high-tech research I've shown you here, and how it has changed our thinking of corneal pathology. I think the ophthalmologists will know, for more than 100 years, Descemet's membrane detachment, that last layer, looks like this and is a well-known entity. Only 2 years ago we showed it's not Descemet's membrane detachment in all cases. In 50% of the cases, the pre-Descemet's layer, the Dua's layer, and the Descemet's membrane detach together. It becomes like a chord of a circle. It's very taut. The management approach is completely different to that than to this. And occasionally, not only are the 2 layers detached from the cornea, but they also detach from each other, and that's called the mixed detachment. So what we knew as dogma for 100 years was now changed, because it's not that, and we know how to treat it. So don't achieve for reward, but don't hesitate to pick up your reward. So if there is one going, and you will see in the UK we have merit awards, scholarships, prizes, honors, no apply, no reply. And for some of these things, even for national honors, somebody has to apply on your behalf. For all the ACCA awards, you have to put in the application. For all the local awards, you have to put in the. Don't be ashamed to put in that application. Oh, I'm going to ask for a prize for myself. Some people feel that. No, you have to put it in, otherwise nobody is going to recognize you and give it to you. So you have to sell yourself through your publications, through your presentations, through your applications. Define and pursue your ambitions, and Shashi said, have a plan B. Not everything works, but always have a plan B. Success is 9 times failure, but that one time makes it worthwhile. As one career progresses, your emphasis changes, your opportunities keep presenting themselves, you make those choices, like I said in the very beginning, and peer recognition comes in various forms. To me, it came in many, many different forms, as Manu has already highlighted, president of many national, international societies. One of the highest accolade was of the Royal College of Ophthalmologists, was the chairman of the Clinical Council for Eye Health Commissioning in England, master of the Oxford and so on. But this was the pinnacle. Last year I was High Sheriff of Nottinghamshire, completely unrelated to my profession, but I think some of it rubs off into society, and that was a post I will cherish. I've finished it, but it was great while it lasted. I have over 450 publications, 54 PhD students. Do everything with heart and mind and with passion. Try to make a difference. Learn from and with your students. And one of my students is sitting right behind me, not paying attention as usual, working on his iPhone, doing emails. And these are some of the papers we published with Manu Matthews. So make your students work. It was a bit of hard work with him, but we got there and we did lots of things together, you know. So they all add up as your team, and they all add up to their career, and so give them the opportunities, make them work, and then they will work back for you. So that's just to illustrate that point. And when you've done what you have achieved, move on. Ask yourself the question, what next? Okay? Think in terms of beginnings, not endings. Every ending provides an opportunity for a new beginning. So that was one of my more later quotes, which I've mentioned in some of the meetings when we give the qualification and degrees to our FRCS graduates in the college. This is one of the messages I give them. Take your family along. This is not something I did very well. Rita at the back held the fort with the kids, but we moved along as a family. And keep your patience at the center of everything you do. This is very important. And again, I'm going to put one of my quotes. Some people might not agree with it, but that's true. The patience will teach you more than any book can. And all these observations I tell you, which have been game-changing in ophthalmology, come from observations on patients' eyes. They will reward you more than any money can. They will think you are God. Try to prove them right. Now this is one example. We are absolutely privileged in the medical profession. A patient mentally challenged, Down syndrome, 43, 44 years old or thereabout, 46 years old. All he did was color images. And his elder brother, who used to look after him, brought him to me saying, his coloring has gone all over the place. We've been to many doctors. He's got keratoconus, very bulgy eyes, and he's got cataract. Nobody wants to touch him because Down syndrome patients going all the time, some of them bang their eyes. If you do a corneograph, it's going to come out. So what do we do for him, you know? And that's the only thing he used to do, and now he can't do it. So I said, okay, I'll do only his cataracts, and we'll give him glasses. Let's see, you know, at least we'll try and help him. Came back with the images done like this. So the pleasure that gives you as a doctor, unfathomable. You have made a difference in somebody's life. And we get these opportunities so many times in our day-to-day life, not once a year, once a month. So we are privileged in the medical profession. We can make that much change to somebody who's like that. And my last point is payback. Give back, complete the circle. Remember that you can never pay back the debt you owe to your parents or your teachers. The only way you can pay back this debt that one generation owes to the next is by doing for your students and your children what your parents and teachers did for you. And on this, I have written a poem which I'm going to read to you before I conclude. The finger that I held when I learned to walk, that showed me the words to speak the talk, that turned the pages of knowledge to teach and pointed to stars for me to reach, is part of the hand that waves me on as I grasp the baton and move beyond into the future, living his dream, knowing how much to him it will mean. Time will pass, I'll stand on my feet. I'll extend my hand the young ones to greet, for in their future I will secure the future forevermore. Be a leader, take your team along. Mahatma Gandhi said, there go the people and I must follow them, for I am their leader. If you enjoy what you're doing, you don't have to work a single day in your life, said Confucius. Always pursue perfection, but never assume you are perfect. Perfection is an illusion. The achievement is in the pursuit of perfection. The day you think you are perfect, you would have become complacent. Thank you.
Thanks, Prof. Dua, for that excellent talk and inspirational to all of us here. I think when people are sitting in the background and your students are working hard, there's a lot going on in the background in the organization of these meetings. So the communication between the organizers is always a constant feature. And one of the key things I would like to say is that our secretary will be giving Professor Dua his memento for his lovely talk, inspirational talk to all of us, and the award for check as well. I'll ask Mr. Iyer, Dr. Iyer, please come over and hand over the thing.
Professor Dua, it is my great pleasure to give you the opportunity to be with us and also give the JAAUK emblem for you. Thank you very much for being with us and really
Prof, I can just come in for the photography. Swem, let's come. Let's do the photography.
Why don't you come now?
Yeah, come on. Anjum.
Thank you. Thank you very much.
I would like to thank all of you. Before that, I would like to thank all of you for having listened to the lecture so patiently. But we must realize that behind every successful man is a woman, and I take that inspiration from Rita, Professor Dua's wife. I think all of us have seen the man in his action, but there's somebody behind him who has made it all happen. I would request Rita to please come up. Rita is a consultant anesthetist in Derby, and she has been, I'm sure, as Prof has mentioned, been instrumental in Prof's success story. And I'd just like to give her this small token of our appreciation for coming over here and being with us. Thank you so much. This is for Nitya.
No, Nitya is going to give them.
Okay. So Nitya is going to give them, and I'm going to give Nitya as well.
Yeah.
You want me to?
No, tell the name of the speakers.
Yeah.
So I can actually.
So yes. So we would like Dr. Buddhadev, Mr. Buddhadev, please come over and take his first gift, please. Dr. Shashi. Thank you, Nitin.
Jan.
Yeah. Nitya, for your lovely presentation. Thank you very much. Yeah. Yeah. So I would like to thank all the speakers for that excellent presentations. I mean, these are lovely Tanjo paintings for our speakers who have been very kind enough to have come over and given this lovely lectures to all of us, and talks to all of us. These are paintings which are made in India, and they're of various deities. So I would request all of you, I mean, most of the people here culturally know it, but we all hold it in high esteem, these paintings. So I just wanted to share that with you. That thank you very much, everybody, for coming along. What we will do now is to take all the questions from the audience regarding all the talks. Of course, Professor Dua is available afterwards as well to meet you. But we'd like to start first.
Dr. Suggest, because it's already 3:50 and Doctify has to attend it. Can we do the panel informally over a cup of tea after? Because between 3:30 and 4 we have time. Sorry to interrupt.
Yeah, so we can have Doctify. If there's any question, burning question, we can take it now. But otherwise, we can have it at tea time. Okay, can I request Doctify to come up and have it?
I will take up 5 minutes max.
Not at all,
Don't
please.
worry, please. I'm not. Could
Can this presentation start?
the first thing I'd have to say, your first presentation speaking about accents. Somebody from the UK, it's exactly the same. We struggle as well, so it doesn't matter where you're kind of originating from. So Doctify, I'm speaking to. Oh,
Quickly switch there.
For those that don't know Doctify, it's a review platform for the medical profession. It started by two consultant orthopedic surgeons, Dr. Simon Saha and Dr. Stephanie Eltz, in 2016. I'm going to wait for the... and we've really kind of grown. UK, we work with 7,000 consultants, most hospital groups within the UK. We've also expanded to the UAE, Germany, and Austria, and going to go into the US February next year. So I want to talk about very quickly the power of reviews and what we do with them. Healthcare is an industry. There you go. What do I press? Oh, perfect. Okay, so the power of reviews. This is very light-hearted. The Mountain 3-Wolf Moon Short Sleeve T-shirt. Nothing particularly exciting about this T-shirt, shall we say, except that it's one of the most reviewed T-shirts on Amazon. 3,357 customer reviews. At one point, it was selling 100 T-shirts a minute. Clearly life-changing stuff. I had a 2-Wolf shirt for a while, and I didn't think life could get any better. I was wrong. Life got 50% better on the 3-Wolf T-shirt. So it really is the power of reviews is there. I'd like to introduce you to Mohammed. Mohammed is the highest rated Uber driver in Europe. I did a little bit of research on him. If he's not feeling good that day, he doesn't go to work. If he's not feeling positive, he's not going in. Would you step into a car with an Uber driver who had a 3.92 rating? Probably not. Maybe you would, maybe you wouldn't. I think I'm a 4.5 rating as a passenger, and I get turned down quite a lot. So we believe in harnessing the power of the patient voice. So there's two aspects to our business. We work directly with consultants, and we work with hospital groups. So from an operational standpoint, understanding where improvements can be made, not necessarily within care, but within the kind of whole patient experience. And from a patient standpoint and a consultant standpoint, online presence. Doctors are so busy, managing an online presence is near impossible. getting new patients and trust of patients, and that trust of patients is within the NHS and within private work. And to give you a bit of background on myself, I didn't go into selling Doctify initially. I used to sell to investment bankers, and then my first son was born with a lung condition, and we managed to find a consultant on Doctify, and so I was like, well, it seems like quite a good thing to do, and yes, so that's kind of how I kind of got into this journey and why I'm here. So how do we kind of do what we do? We try to meet patients at a time and a place that works for them. We make it as easy as possible for patients to actually leave feedback. Very, very simple process, be this through an app, be this through integrating with patient management software that you already have. Very, very straightforward 3-step process for patients. Treatment tags, and this is, we've talked about people starting off in their careers, and then as consultants become more specialized, they tend to focus on a specific procedure or a specific treatment, and we want to make sure that specialty, that expertise is reflected online, and that's done with treatment tags, so that if a patient is looking for somebody to do a meniscal repair, the kind of go-to one there, then they can find and read about exactly what to expect when they go view that consultant for a meniscal repair, and it's reflecting that online, and it's not always that easy to find out whether when a consultant specializes in a specific procedure or in a specific treatment. So we utilize that to manage your online reputation, look at kind of which hospitals a consultant is working at, make it as straight. We interestingly did some research, and when patients are looking for their healthcare needs, if it's not a burning healthcare need, it usually comes outside of working hours. So being able to kind of call, book, leave a message for a secretary happens outside of working hours. And the other aspect that isn't in this presentation is peer recommendations. So a fantastic group of alumni here, and being able to recommend other medical professionals for patients. That's a fantastic ringtone. Is really, really strong. And as a patient, as someone who's used Doctify as a consumer, I guess, when you see the feedback from other patients who've gone through similar health issues, and then you can read from other medical professionals, other medical peers, about how they would recommend that doctor. And everyone here, I'm sure, has a kind of a black book or a network within their head as to who they would recommend if their child had an issue, or their wife or grandparent, whatever it may be, and we want to reflect that online. So it improves presence on Google in terms of, if you've ever Googled, you should Google yourself, because it can be quite difficult to find these things. And then if you have a website, it's that third-party validation. The World Health Organization came up with an interesting piece recently, which was, that there's such a lack of trust in the world that we live in. Having that third-party validation is just so important. As I say, we work with most major hospital groups, 6,000 consultants, 30,000 medical professionals worldwide, so hopefully we're good at what we do. But I won't leave you any longer. Our vision is to make sure no patient is left unheard, and that is that. Thank you so much. So thank you for the day. Fantastic. Cool.
Thank you. Thank you. Thank you, and we are very grateful to Doctify for sponsoring this CME here. We also thank the other sponsors. DocStay has sponsored the morning photography session, and Servco, the company, is also sponsoring our YouTube channel and our virtual presence. I think
this particular episode.
Yeah.
This particular episode. Okay. Yes.
Can I
Prof.
have a burning question?
Sure.
Can I ask that?
Sure. We will take questions.
The GMC.
Yes. Sure. There are a few questions actually, and we do have some 10 minutes time, because we intend finishing at 3:30, so we do have time.
So, I know you have excellent ideas and models about this welcome to the UK and induction and all that. But I think the presumption is erroneous that only the IMGs need it. I think if you put the cohort of local graduates through that and ask them the question, did you benefit? I won't be surprised if a large proportion would say yes, they did. And I think that comparison has to be validated by asking the local graduates. For example, the life in the UK test, about 40 to 50% of UK citizens fail it, which all IMGs have to go through. So we presume that all UK citizens know everything. I tried that test myself. I couldn't do it. I've been here 40 years. So that may be research that Shashi or you could do and see to validate this bit. One or two technical issues. You have the IELTS and the OET that you recognize in the GMC. Now, not all universities recognize the OET. So I have an example of a graduate who did OET, got GMC registration, because I'm probably the only surviving individual sponsor for GMC by exemption of the PLAB route. I've been doing this for many, many years. More than 2 score people or maybe 30 people have gone through my system. And she was not given a PhD registration at the University of Nottingham on the basis of the OET, although she got GMC registration. So there has to be a sync. Now she had to sit the IELTS again, and had she known that, she would have done it in the first place. So this is one bit that slipped through the net. And I don't know if it's still true, and this is another example of one of my students. She came from overseas with the overseas passport, right? She went through 5 years of medical school in the UK, and 5th in her batch, she passed. But she was forced to sit the PLAB test. A UK medical school graduate, because the passport she held was not of this country, it's an overseas. So what are we comparing? Are we comparing professional standards, or are we comparing nationalities? Because she's of and I think that law still exists. And I know Peter Rubin was then the chief of GMC, and I asked him, and he said, Harminder, I don't make the rules. But he agreed it was not. But I think it's still there. So it's clearly an issue that needs to be addressed. And the final point is about this PLAB test. How many? 15,000 people. Half of them say they pass. You've got 7,500 people passing, and how many jobs have you got every year? So are you doing the right thing? Are you creating a demand and meeting a demand, knowing that many of them are destined for failure? It's like all hospitals. Our car parking space in my hospital was 500. Now we have 1,500 consultants. We still have 500 car parks. Every morning there's a chaos. It forces us to come earlier and earlier, but 1,000 people don't get car parking. So that's what we are creating. And is it the right thing? And how can you regulate? I know you can't stop people sitting the exam, but how do you regulate that? Those are some issues.
Thank you, Prof. There are a few questions. Mr. Pandya, would you like to ask a question?
This is not a question, this is something, an observation. This was followed up from Baba Garwa case. This is from Baba Garwa case.
Dr. Mr. Pandya?
Sorry. This is not a question, this is just, can you hear me? Yeah, this is an observation. And one of the things which really is a bonnet in my bee, or a bee in my bonnet, is the issue about manslaughter, or something seriously happens and a patient dies, and there is a whole caboodle breaks loose in the NHS trust. The trustees want to protect the institution, so there is a internal inquiry. The personnel committee comes in, disciplinary process starts, the whole GMC, but there isn't a process where you investigate parallelly the failures of the employers. The environment under which, like Baba Garba case is a typical example. That's one thing. The other bit, so by the time the report goes to coroner, this report is missing. So there's no balance at all. It's a governance issue. So GMC needs to look at those things, and I tell you how the GMC could also look at it. You take the NHS trust, each trust. There are many cases where number of cases come up on a tribunal, the discrimination cases, and the trust pays through the nose. It's really big money, public money. The whole process is expensive for the trust, is expensive for the individual, and the amount of resources that trust spends in terms of human experts or professionals dragged into it. If you do not have a system where every case you see, and they are saying, look, because I failed because there was no system, I failed because there was no lighting, because there was no nurse available. This is not picked up, and if even it's picked up in some corner of some report, the CQC type of organization which inspects the provider's quality, there is nothing on that side. With the GMC has a capacity to say, we had 15 cases from the same trust, all these have said this is not happening, this is happening. So what about passing it on to officially and formally, so the CQC can actually say, yes, when we inspect you, this will be in report, and then a linkage with the Department of Health saying there has to be a need for immediate team to come in. Don't wait for the trustees to ask for questions, because all the people in the BMA, the medical director to HR protects themselves. What it needs, the Department of saying, we will investigate you, and if necessary replace the management for 6 months or 9 months to clear this thing up. So I think this is a two mismatch, where that's why nothing gets done. A person gets solidly victimized, an apology comes in, or £500,000 settlement, but this infrastructure remedy is not there. So CQC and other bodies come in inspection, they go away, and they don't note any of these things. It doesn't go in record, and nothing happens afterwards from department. So department was looking for funding, money saving exercise. They got to trigger these things much more effectively.
Thank you, Dr. Pandya.
Thank you, Mr. Pandya. That was a very valid comment.
Need an answer from
Yes, there will be a rebuttal. Mrs. Gray, please.
Thank you, Dr. Biswas. So, Professor Dewar, if I could come to your points, some really, really useful points on the OETs and the IELTS with the language test. We do ask for those too, but if somebody's been practicing in an English-speaking jurisdiction for 2 years as well, that would tick that box, if I can use that phrase. So I'm not sure why your student from Nottingham had that issue.
The student was
From Egypt, yeah.
You have to set the OET or JMC. So the university said, no, we don't recognize it.
That's odd.
So unless we have a sync between JMC and the universities, we'll have these people falling.
Yeah. I will take that feedback back to colleagues in the education department, because that does seem odd, because if we've accepted that this doctor can pass our requirements and treat patients, I'm not sure why the university would have an issue. So that's something that I'll feed back to. So Dr. Colin Melville, who's our Director for Education and Standards, I'll pass that to him. You make a very interesting point about Welcome to UK Practice, and I'm not sure is the honest answer if we've ever given that some thought. I think the focus is on, as we've said today, people who are not used to the UK having that workshop, but it's certainly something to think about. The other thing I would say is FY1s. So part of my team, the regional liaison advisors who engage with cohorts of doctors, we talk about our standards and thresholds and how to practice and not get into a pickle with the GMC, if I can put it that way. So we will talk to cohorts of doctors from students at medical students at university, FY1s, FY2s, right up to consultants, and we'll talk about things like leadership behaviours, professional behaviours, raising concerns, speaking up, all of these sorts of things. So there's an awful lot of workshops that are offered and taken up by UK graduates, but I've never thought of that as the honest answer, so I'll give that some thought, because you make an interesting point. And talking about colloquialisms and moving from, you might have qualified in London and you move up to the northeast, it's a completely different dialogue, isn't it? So I'll take that back. I don't know what the answer is, but I'll have a think about that. I think the other thing you were talking about is, are we comparing standards or nationality? We should be comparing standards, because what we're looking at is, if a doctor's got a primary medical qualification from wherever, and we look at that and we say, yes, they've had the 6 years medical training and they've passed all the tests, they meet the criteria and they're eligible for registration with us, then nationality should not be an issue. So it is about the standards, because what we're looking for, it doesn't matter where the doctors come from. But if that's coming up, So maybe we have a talk offline and have a little bit more information about that particular case. And as I was saying before in the presentation, registration, that it's so nuanced. You know, we've got. I was talking to a registration colleague just this week, and a student who thought they'd ticked every box and had the criteria, and there was something missing. We had to feed back. So you need to look at each individual case, but it should be just about, have you got the standards, skills, knowledge and experience to practice here?
And there's a very interesting, all of us that have experienced this, we talk so much about people who can't speak English. We don't talk about doctors who can't speak Hindi treating patients who can't speak English. And we have so many people in this country who don't speak English, but they are allowed cash plans to be treated by doctors who don't speak their language, and we make no distinction there. But the moment you can't speak English, you're not okay to treat patients. And as the patient can't speak English, you're okay to treat.
It's an interesting comment.
Cultural competence is trying to get the institutions to be culturally competent.
Yeah, and I think this goes back to the equality, diversity and inclusion training, doesn't it? And looking at education, we're talking about medical textbooks. Are they inclusive? Are you looking at dermatology? Is it just white skin? There's a lot of work going on with that. And I think Dr. Pandya makes a good point. It's about this cultural intelligence and competence. Thank you. But yeah, that's an interesting point. And again, as the regulator, we're looking at registering doctors, but there's something to be said for giving that some thought. And I really liked your quote at the end, question the answers. But yeah, you've given me a lot of pause for thought, Professor. Thank you. Did that cover all of the points you were making before? Yeah, thank you.
Jan, I have a very quick question to the panel. Two parts. Does Nitya know about the importance of indemnity when you practice in the UK? Yes, she does. So she must be more of an exception, because many of my juniors don't seem to know. Is that part of your course? Are IMGs actually, is it clarified that indemnity that we get as part of the crown cover is different to what we get when we get a private insurance? All of us get our car insurance, but we don't know the value of indemnity till you burn your fingers, especially as IMGs. My personal gratitude to the GMC for indicating
many of us
when you clarify after your investigations. Thank you.
So just pick.
Because it's not just indemnity, because when you are before the when you are before the tribunal, you are on your own.
You need to come here.
Mic.
You can't.
No, you can take the hand mic.
Take the mic, because on your online people can't hear you.
I'm just making a comment that when you are faced with a disciplinary action, from the day one you need a good advisor. If you are not protected, then you are in trouble, because you are in the tremendous isolation. Mentally you are gone into Coco's land. So you need somebody who can hold your hand, because I have visited so many doctors when they're in difficulty, and even first 2 days difficult to talk to them. The second thing is when you are called before tribunal, if you don't have a good advisor, believe you me, the HR and other people will have a lawyer's advisors. They're experienced in harassing you. So it's important that on employment side you also have a trade union or some party which really has the capacity to be able to stand up and do necessary inquiry. If you're not done, just indemnity will not cover. Indemnity, the main indemnity will cover with a lot of other serious issues. But employment conditions, small things can blow up in many ways. So you need to be very much protected, and so make sure your membership is paid, because in some 10-15 years ago we had some concern about BMA. I'm not trying to blame, but I think there were a lot of members when we protested against Downing Street's issue about immigration. The question was BMA competent enough to deal with the culturally sensitive issues of the BME? So the MDS came out from that issue, that the people who advise and support have to be culturally sensitive and be sympathetic to you rather than immigration status and all that. So I think employment side is also very critical, not to leave yourself unprotected.
Yeah, I think on that note, I'd just like to just say that the protection which the employer gives you stops when the employer is subject to stress. So at that point of time, the employer will protect himself, and your will come secondary.
It's a basic. The moment you are accused of anything wrong, when your friend complains against you, your colleague complains against you, you march over. You are on your own. Your best friend And believe me, I think the best friend will be not your friend but feeding back to the institution. And the institution will do that number.
Thank you, Dr. Pandya. So just on a couple of points there, I'm glad, Nithya, you know about the indemnity position, and Barbara, that is all covered in the Welcome to UK practice. We make sure, and in the medical students as well, when they're workshops with them, to make sure that they understand the importance of it. So that is put out there. Just picking up on the representation, and it is tricky, and I do take your point, Dr. Pandya. If a doctor gets into difficulties and they go to a tribunal and they haven't got a medical defence unit and they haven't got a legal representation, it can be difficult. And what the tribunals and the MPTS now is separate from the GMC, but it adjudicates. So they have a duty of care to the doctor who's not represented to make sure that they understand the rules and they understand the position, and they can't give advice on a case, but they will make sure that the doctor knows what the process is. So yes, we know that that's difficult, and we refer in signpost doctors to what's it called? There's a pro bono barrister's firm that will look after doctors. There's other signposting we can get to see if they can get somebody to support them. I think the other thing just to say as well is any doctor who is referred to our fitness to practice processes, we fund a doctor support service that's run by the BMA, but it's funded by the GMC. So if a doctor hasn't got representation, they do get that support from there. I think the other thing I'm hearing, and I 100% agree, the process at the moment is very adversarial. And one of the things that we've been hammering on the door for the Department of Health for years now is regulatory reform. You look at the Medical Act from 1983, it's nearly 40 years old. We look at our fitness to practice rules, very old, very prescriptive, very clunky, and you'll hear Charlie Massey talk about this with some passion as well, any of the forums he goes to. We absolutely need better legislation that gives us that ability to be more agile, more digressing. We want to get away from the adversarial thing. Nobody goes out to make a mistake. Things happen. We need to be able to deal with those proportionately and at the right level, and get away from this adversarial, so that the doctors are supported, patients are safe, and the cost, as you said, to everybody going through a hearing and going through these processes. So, yeah.
Can I just add one more point here? That the system, what like Professor Dua was saying, and many have said before, the system existed before the certificate for eligibility for specialty registration came along, wherein they had to play this game of snakes and ladders, as they call it. But that system has changed since Article 14 was introduced and certificate of specialty registration was put in place. But that doesn't come out very clearly on the GMC website as a prominent structure or part of the system. It all looks like as if a particular training program is essential for each and every one to go through, and which is not true. All you have to do is to prove to the GMC your level of competencies in your level areas of interest, and if you can prove that, you can go straight away and get your registration sorted. So a lot of people can actually stop wasting the time trying to get into a training program when they don't need to. So I think that needs to come out very clearly on the GMC website.
Thank you. And again, that's really important feedback to have. I think just looking at the routes to registration, there's a lot of work going on about the different routes, and you're right, we need to be very clear of what doctors need to get on the specialist register.
Mr. Pandya, do you want to say something?
Just one comment. I think this is important for
Please.
I think this is very important for bodies like JIPMER and other organizations. Earlier we tried a kind of early intervention program. What it meant that in every NHS trust, the BME needs to get together, work with the institutions around them, the professionals around them, to make sure that if somebody is in difficulty, there is a diffuse identification and diffusion mechanism. If you don't have that, and if you haven't, that could identify a number of what you call hotspots. And that hotspot can also reflect on the way the managers are trained and delivering it, because reducing before the issue comes up too hot. So that mechanism would support individual in difficulty, and also so bodies like JIPMER and others needs to talk to the chief executives and others, so that if there is any way they can salvage before somebody ending up in a disciplinary train. And so I think this is where our own people who understand the system now, who are very keen to support BME groups, they got to get involved at that level, because if we do that, we will help our own people who are getting disillusioned at the time, but also pick up the culture which is not working, and you can then lobby the board members or a chief executive to resolve where the difficulty is in the trust.
Thank you, Mr. Pandya. That was a very good comment, because we do realize that there are situations where we can preempt a situation from going out of hand, and maybe by acting early we can even reduce the GMC's burden, because a lot of them are local issues, and before it goes nationally there should be some resolution mechanism which can preempt, as you said. So these are all works in the making, and I think all the organizations can communicate better, and we can evolve something in future which will be very useful for everybody. I will end now because we are exceeding the time, but I've just got a comment to make addressed to Shashi. You've been very quiet. But what I would like to request you is that just like you are doing a lot for IMG training, I think there is a scope for training many assessors and appraisers and senior mentors like us who are also not aware of all the things that we can do in our day-to-day practice, and that can be addressed through workshops which you are already doing. So that's another area of need. And communication wise, I feel that it's all down to lack of better communication. Like Mr. Pandya, you said, when a problem is addressed, the lessons from it is not disseminated widely. The organization doesn't learn it as a whole for future preemption like that. And similarly, what Prof. Dua was also alluding to was, yes, before I was seeing when the NHS was, say, 20-30 years ago, there was so much careful manpower planning that all the trainees which are coming out will have their jobs waiting. All the people who are getting training posts are passing out from previous exams. But now I think it's kind of lack of planning, lack of careful consideration. The number of IMGs might be exceeding the number of training posts. So I don't know what the answer is, but it's not in our hands. We have to communicate better. On that note, I would like to end this session. I would like to pay particular thanks to Anant, because he was the man behind the audio-visual setup. And thanks to Prabha, our colleague, and she has been amazing for the CME. We can have a tea break outside, but those who are members of JIPMER will be staying back because we'll carry on here for our AGM. Thank you. We would like a group picture with all the speakers, so can they come to the front, please, and Anant will take a picture. Thank you.
JP?